crime, and I have done work with them.
Okay. Critical Incident Analysis Group, CIAG, University of Virginia.
Yes.
Okay. Behavioral Analysis Unit, as you told us yesterday, for the FBI at Quantico, right?
That's right.
Psychiatric consultant to the Virginia Department of Corrections, medium, maximum, and supermax facilities, right?
Yes.
Continuing on with your experience, sir, as a witness in this case, you'd agree with me that you were involved as a psychiatric consultant with the Macro Task Force on-site consultation for the Australian Police Service.
Yes.
Former Soviet Union project, Republic of Georgia, TBILISI, Georgia. You were involved with that, sir?
Tbilisi.
Tbilisi, yeah. Critical Incident Response Group for the U.S. Air Force. You're in the assessment unit?
Yes.
Crisis Management Unit, investigative support for Operation Gray Sunset, Jordan.
Correct.
Crisis Management Unit, investigative support unit, critical incident response in Montreal, Quebec.
Yes.
FBI, National Center for Analysis of Violent Crime, Operation New Hope.
Yes.
Bureau of Criminal Investigation, that's BCI, for the Department of the State Police. Would that be Virginia?
Yes.
You also have an interest in and have studied or written about various topics in your career, correct?
Yes.
Okay. Hostage negotiations course, crisis management unit. You were involved with that, is that correct?
Correct.
That was a number of years ago, though. I guess that was like 1996.
That's right.
But you've been involved with the FBI for a long time, right?
Yes.
Fair to say that you're a government man?
Objection.
No, sustained.
Hostage negotiation course. How about Virginia Department of State Police? You involved with them as well, sir? Yes?
Yes.
Advisory positions. You deal with Islam in prison is one of your interests, right? That was a TV program or something?
Correct.
Talk about National Institute for Justice, Standing Committee to advise the Department of State on unexplained health effects on U.S. government employees and their families overseas, right?
Yes.
Analysis of pre-attack behaviors of the Las Vegas shooter behavioral analysis unit for the FBI.
Yes.
Skipping ahead, papers published. Now, when a doctor or a psychiatrist, or even any doctor really, I guess, publishes a paper that's of interest to other doctors or people, that's called a learned treatise, right? Peer review?
Yes.
Okay. Can you tell me, what is peer review? What does that mean when you're dealing with a person's focus and interest in writing about what they're focused on?
So a peer review journal is one in which once an article is submitted, a paper for publication, that goes to qualified people within the same field who review it and make determinations about the quality and whether or not it should be published. Oftentimes, there will be some edits or suggested edits from those who have expertise. It's a blind process, so if I submit a paper and it's peer-reviewed, I don't know necessarily at all who is reviewing it, but it's a way to ensure quality of articles that are published, and that's just an important standard.
So it's kind of a rigorous standard to make sure that what you're writing about is reliable and would be helpful to others that are interested in it, right?
Correct.
Okay. So, for example, also it depends on where you're publishing it. You can put something in the National Enquirer, or you could put it in International Psychiatric something or other, right? Which would be a better publication.
I don't think the Enquirer is peer-reviewed, but
So you certainly would agree with me that the International Journal of Law and Psychiatry is a respected source for learned treatises, right?
Yes.
And you would agree with me, sir, that you've been in here telling this jury all about Lindsay and how she didn't hear voices or did hear voices or exaggerated and lied. Have you written any articles at all on the concept of auditory hallucinations?
No.
Have you read any of them?
Read any articles? Yes.
Yeah, okay. You certainly have heard of Dr. Philip Resnick, yes?
Yes.
And it's fair to say, and tell me if I'm wrong, is he literally a world-known authority in your field for filicide or the killing of children by their parents?
Yes, he's well known.
And is he also well-written as far as auditory hallucinations, same stuff you've been testifying about?
Yes.
And he published an article in the International Journal of Law and Psychiatry, which is considered to be, if you know, a landmark article about, and I captioned, listening to voices, the use of phenomenology to differentiate malingered from genuine auditory verbal hallucinations. Now, did you read that article?
Yes.
So it is a peer-reviewed article published in a recognized journal, correct?
Correct.
Your Honor, I would offer this under Commonwealth versus Sneed for the jury, if they wish.
Objection.
Counsel Garcia, sidebar.
Your Honor, while that copy is being made for the district attorney, could I continue?
Sure.
Thank you. Leaving aside peer review article and the article written by Dr. Philip Resnick, sir, for a minute, papers that you published And you have in your resume, it says peer-reviewed, so that's just what we were talking about, right?
That's right.
All right. Using the moral situational action model of extremist violence to assess fluctuating levels of risk in women, the relevance of risk promotive and protective factors. What does that mean, levels of risk in women with extremist violence?
Well, looking at risk assessment in terms of violence and what may be mitigating factors, in other words, decreasing the risk or the threat, or increasing, that would be enhancing factors. But this is looking at a group in terms of research.
And it's research about women that are involved with extremist violence?
Yes.
Okay. Assessing, strike that. Using the moral situational action violence risk model for assessing women involved in extremist violence, an empirical study. Is that a similar article?
Yes.
Operationalizing theory, a moral situational action model for extremist violence. That would include guys plus women, I guess, right?
I'm sorry.
That would include men plus women, I guess, right? Because it doesn't say women. Suicide, terrorism, performance, violence as a public plunge. You wrote that, right?
Correct.
It's another interest. Crisis leadership and military community resilience. You wrote that, right?
Correct.
Painting by numbers, capturing the pathology of socio-political conflict, dealing with depression amongst Palestinians. You wrote that, right?
Correct.
Psychological challenges of bioterror. You wrote that, right?
Correct.
Trauma and intergenerations transmissions in Kuwait. You wrote that, right?
Yes.
Recognizing borderline personality disorder in the family practice setting. You wrote that, right?
That's right.
Mortality among elderly patients discharged from a state hospital. It's one of your interests, right?
That's right.
Postpartum psychosis induced by bromocriptine. That's the one that you told the jury about originally that you published 40 years ago, right?
Yes.
Okay. Morality and the radicalization of women. What is that? What was that all about?
Could I be refreshed with that? I'm
Sure. It's just, I mean, you can look at your resume if you wish. I'm just going through it. It's under B, books and chapters. This one is the first one, and it deals with radicalization of women. A handbook, I guess, for terrorism studies. You remember that? It's only 4 years ago.
Yes.
Okay. Application of big data for national security, a practitioner's guide. You wrote that, right?
Correct. I was one of 4 editors.
Crisis guide of psychoactive drugs and poisons for the crisis negotiation unit. You wrote that, right?
That's right.
International handbook of threat assessment, right? Yes. Protection of children during armed political conflicts, a multidisciplinary perspective, right?
Yes.
The negotiator's guide, like when somebody's locked in a building and they're threatening to kill people or something, the negotiator's guide to psychoactive drugs, 2nd edition. You wrote a chapter on that, right?
That's right.
The negotiator's guide. And it goes on and on with the negotiators and things like that. Terrorism negotiators, right? It's fair to say that's your focus?
Correct. Well,
Well, I know you can talk about postpartum, but I mean, I'm asking you if your resume that you prepared, I imagine, well before you were hired by this DA's office, sets forth your interest, right?
yes.
Okay.
The characterization of negotiation as trying to stop killers is not accurate.
I'm probably wrong.
Comprehensive.
I apologize. You see it on TV, the negotiators, and they're trying to help people that are being kidnapped
On a bridge, in crisis, something like that. So,
Just a few more, Doctor. Panels and symposia. You'd agree with, let's see, national security implicate. I just want to run through a quick attachment theory, mental wellness as it relates to threat management, threat assessments, corrections, psychiatry presentations, substance abuse and misuse in prisons, perspective on providing medical support during conflict and chaos, targeted violence in the media, lessons from history, the profiler of poisons, understanding the female extremist, crisis operations, leadership, how to fool doctors by injecting chemicals into muscle to obtain opioids, a prison inmate comes clean. Did I read all those topics correctly, sir?
Correct.
Invited lectures, talk about extremism, terrorism, the future of policing, children in long-term abductions, how to prevent terrorism, mass shooters, U.S. prisoners, religious rights, religious radicalization, terrorism and the unknown enemy. Basically, that's what your focus is, sir, correct?
No.
And that's coupled with your experience of the two people or so that you recall dealing with in your, it's not a practice, but working for the Bureau of Prisons or the state for Virginia, the people that are in jail. That is the sum total, to be respected, of Dr. Sadoff, correct? I mean, you treated two people. You've written a lot about terrorism and other issues that we went through.
That's not at all a correct characterization.
Oh, I'm sorry, because I read your resume right?
Yes.
Okay, and I related what you indicated to the jury, your experience when I asked you about patients or treating people. I said that right?
I've been treating patients, and I continue to for the last 40 years.
Now, in all of your experience, sir, have you ever treated a woman suffering from postpartum psychosis?
Yes.
When?
In the late 1980s and also during the 1990s when I ran a unit in a state hospital.
So this would be women, 1980s, about 30 years ago or 20 years ago, depending on which one, in a prison that you were...
No.
Oh, it wasn't.
In a state hospital.
State hospital. Were they
Correct.
committed? Were they there because they wanted to be there, or were they committed by order of the court?
Yes.
Yes, what?
Usually committed.
Okay. So other than that, sir, do you have any interest, writing, knowledge about postpartum depression, postpartum psychosis?
Well, it really is a requirement when you assess and treat women to be aware of their histories and making determinations. So that has continued really throughout my career, men and women.
What did you just say? Can you repeat that again? You're treating women with what?
Treating women with psychiatric problems, serious illness, psychosis.
So when you defined for the district attorney the concept of, let's say, psychosis yesterday, were you referring in any degree to a woman who has had a baby and is in a period of postpartum depression, shall we say?
Yes.
Okay. And when and how were you treating those people?
That was during the period of 15 years when I ran a unit of men and women who came in with serious psychiatric symptoms.
So what would you do? Would you analyze them? Would you talk to them, counsel them? What would you do while they're in the hospital?
Well, do a full assessment with a multidisciplinary team and make determinations about proper treatment, proper therapy, medications and the like to treat the symptoms.
And generally, what would the symptoms be, sir, in your experience?
Symptoms of postpartum depression?
Yeah.
Okay. Well, certainly within that period of time around birth or after birth, the DSM has a 4-week period. Others expand that to as much as a year. But certainly depressive symptoms postpartum are similar to the symptoms that you see in a regular depression. You can have suicidality, you can have guilt, changes in appetite, changes in weight, changes in concentration, changes in physical activity. You can also have significant problems with sleep, either sleeping too much or not enough. So these are depressive symptoms that come in the postpartum period and require assessment and treatment.
Are you aware, sir, in your practice or studies of the number of women that commit suicide during the postpartum period? Are you aware of that?
I can't quote you a figure.
Do you have any clue at all?
No.
Would you agree with me, sir, that one of the unfortunate components of a woman who has had a baby and is suffering from postpartum depression and living with it, that can, on a dime, turn into postpartum psychosis very quick, right?
It can be rapid.
And you indicated, sir, that there, according to the DSM, is a 4-week cutoff for symptomology, and then you mentioned that there are others. Is it the World Health Organization that you said that talks about a year?
Correct.
There are some other psychiatric organizations that talk about different periods of time, 6 weeks, 8 weeks, right?
Correct.
So when a woman is dealing with these symptoms and goes to a doctor, or even you, when you're treating, as you indicated 15, 20 years ago, you were treating, is it important to take a blood test?
I'm sorry, can you repeat that?
I'm sorry, my bad. Is it important to take a blood test?
Is it important to take a blood test?
Yeah, you just went through the whole thing about we're going to have the team and they're going to evaluate and we're going to prescribe. I'm just asking, is it important to take a blood test of the patient?
Based on the presenting symptoms, based on the history, based on medical history. For example, if someone has recently been in a hospital and been treated, there may not be a necessity for drawing blood again, depending on the types of symptoms that you encounter. It's not a standard that everyone who presents to a psychiatrist requires blood tests.
So if you're a psychiatrist who's been practicing private practice for about, I don't know, a month, maybe 2, and is prescribing antipsychotic medications, selective serotonin reuptake inhibitor medications, benzodiazepine medications to a young woman who is complaining of what the young woman perceives to be difficulties postpartum. Is it important to take a blood test to find out what, if any, prescription drugs they have on board in their system?
To check and find out, did you say what drugs are on board?
Yeah, I mean, you're treating this patient, right? And they're coming off the, hypothetically with you, but they're coming off the street to see a psychiatrist for help, right?
Yes.
And if they're already been prescribed drug after drug after drug by a particular doctor with her 2 months of robust experience, is it a fair statement that you should take a blood test of that person?
Well, it really depends on the medication. There are some medications that really require blood tests because of levels and the like. Many psychotropic medications are not easily, there's not an easy test for the amount of medication in the system. So it depends on the circumstances, and it depends on the medication. I mean, for example, lithium or carbamazepine or valproic acid, those are all mood stabilizers. Certainly, taking a blood test would be very important. So it depends.
Depends. Can I just ask you to spell those two drugs that you just pronounced for the stenographer, please?
Carbamazepine.
Yeah.
Carbamazepine.
Okay.
Valproic acid, Valproic, acid, also known as valproate, Valproate. And did I mention lithium?
That's not a hard one. The record has to be accurate, that's all.
Understood.
Okay. Now, doctor, are there other tests in your experience that are or can be or should be administered to a young woman or a woman who's had a baby and is coming to a doctor like Dr. Tufts, for example? Are there other tests that can be administered to determine if, in fact, that person is suffering from postpartum depression?
I'm not aware of any specific test that specifically diagnoses depression. Years and years ago.
Postpartum depression, sir.
Pardon me?
Postpartum depression is my question.
Correct.
Depression. I know you want to say it's the same thing, but postpartum depression is my question.
And you're asking if there's a blood test for postpartum depression?
I'm asking if there's any tests at all that a psychiatrist can or should administer to the patient coming to them for help.
Well, there's the Edinburgh scale, which is a self-report that patients fill out for who are postpartum.
You looked that up last night?
No.
Well, you knew about the Edinburgh scale?
Yes.
You administered the Edinburgh scale?
Pardon me?
Have you administered the Edinburgh scale?
No. It's a self-report, usually given by nurses.
Nurses, okay. In any event, it's a scale that is a useful tool to determine the level or degree of depression that a person may be expressing that is suffering from postpartum depression, correct?
That's right.
And do you know what the numbers are on the scale? Like, is it 1 to 23 or is it 1 to 50, or do you know what it is?
It's a 30-point scale.
And when you say
so 1 to 30, as I understand it.
And when you say a self-report, the patient would then advise what symptomology they're suffering at that particular point in time, right?
Correct.
And then the doctor would then determine whether or not there is a risk or an extreme risk or a deadly risk of this person committing suicide, harming someone else, whether it's a baby or anybody else, and determine what the level of their postpartum depression is, right?
Yes, it can help.
And did Dr. Tufts administer Edinburgh test to this young woman?
I know that, Ms. Clancy, there were a number of Edinburgh tests that were given to her, so that there are some scores in her record. I can't recall which practitioner gave her the Edinburgh test, but I do recall that there are a number of scores within her medical record.
Right. And what was her highest score?
The highest score that I recall was 23.
23 out of 30, right?
Correct.
And over 15, the patient is in pretty serious trouble, right?
Over 15 is concerning, definitely.
Right. And she was 23. right?
Yes, I believe so. I think they ranged from 19 to 23, just
Right,
from my
they
memory.
increase as time went by, right? She was getting worse,
Correct.
right? Yeah. All right. And in addition to the regular blood test, which costs like, I don't know, about $100 to administer a blood test to see what somebody's got in their system. It's not a lot of money, right, for the insurance company.
I just didn't hear you.
Blood test. It's not a lot of money for an insurance company to pay, right, to cover.
Correct.
Okay. So do you feel that it is reasonable medical procedure for a psychiatrist dealing with a woman who is expressing under the Edinburgh scale off the charts or serious trouble, who is on medication, as we went through, the antipsychotic drugs, the SSRI drugs, the amitriptylines at the end of the period of treatment with these people, the benzodiazepines, it's helpful to take a blood test, right?
It can be.
And is that, in your opinion, sir, to a reasonable degree of medical certainty, a step that should be taken by a competent doctor?
That taking blood tests can be appropriate, yes.
And then there's an additional blood test that you can use when you're dealing with a woman who's suffering from postpartum depression or coming to the doctor for help and they have significant narcotics or prescription drugs in their system, and that would be an enzyme test, right?
I'm not aware of an enzyme test being typically available or used.
Well, it costs a lot of money, doesn't it? Like it costs a couple of grand?
I don't know.
All right. In any event, sir, are there any other concerns that one would have if they're competent and they're treating somebody that's come to them for help in addition to a blood test and perhaps enzyme test to determine the metabolizing aspect of the person's system, metabolizing or processing these drugs that are in their system, the enzyme test? Are there any other tests or concerns that you have with a woman whose postpartum depression complaints come to your doorstep?
Well, depending on the presentation, sometimes it's helpful to check thyroid function. That can certainly be a cause of psychiatric symptoms.
Did they do a thyroid test on Lindsay?
No.
That's not a lot of money that the insurance company would complain about, right?
Correct.
One of the things that I just don't want to forget, sir, is that the district attorney asked you, while we're talking about the drugs, about the Lamictal, otherwise known as lamotrigine. Did I pronounce that right?
Lamotrigine, yes.
Lamotrigine. And she said that Lamictal, it has a side effect of a rash, right? You recall that, sir?
I think I said serious rash.
No, I think she said rash. You may, it's up to the jury what their recollection is, but you may have said serious rash, but we both agree. It's a serious rash, right?
Yes.
In fact, it can be fatal, right?
In very rare occasions, yes.
It can be fatal, right?
Yes, in very rare occasions.
Well, if one person out of 1,000 gets Stevens-Johnson syndrome or prurigo nodularis as a result of taking that medication, that's something that we should not tolerate as doctors, right?
Risks and benefits are something that every physician, every prescriber needs to think about.
So you've heard of, as it relates to Lamictal as a prescription drug, what's called 10. You've heard of that, right? As a side effect?
Yes.
And that means what?
It is a pretty severe reaction of the skin, as I recall, causing blistering. I mean, it's very significant.
So if you have a young woman who is a nurse, an RN, who worked for 7 years in a very prestigious hospital's labor and delivery unit, who was so nervous about drugs that were being prescribed to her that she would at night sit in her kitchen on her phone and Google all sorts of side effects of narcotics, the drugs, the Seroquel, lamotrigine, all of these drugs. Is it an unreasonable decision for her to say, I don't want to take that drug, in your opinion?
It seems like you're asking, is it reasonable to decide not to take the drug?
Yeah, that's what she did. That's what you told us yesterday. That's what the DA asked you yesterday, right?
It was a decision that she made.
And in your opinion, sir, after we just went through all of this with the TENS, with the toxic epidural necrolysis and all the rest of that, and she's a nurse, and she's looking up these drugs that she's being prescribed and says, I don't wish to take that drug, in your opinion, to a reasonable degree of psychiatric certainty based on your experience, is that a reasonable decision for her to say, I don't want to take it?
The benefits of that drug are profound, and millions of Americans take that medication and find it to be very important for them.
Doctor, you're an intelligent man. You're a doctor. You've got a lot of experience dealing with the prison system. We've already gone over all of that. You understand my question, don't you?
Yes.
Is that a reasonable decision for Lindsay to make, to say, I don't wish to take that drug? Based on all the side effects, whether or not it's rare that people die, whether or not it's rare that they break out on their skin with these permanent lesions and bleeding pustules, is it reasonable for her to say, I don't want to take it?
In her mind, it was.
Yeah. And certainly, we don't want to leave it with the jury that she's so vain that she just didn't want to take something that she might get a little rash with, right? In any event. Now, have in mind, there's no blood test, there's no enzyme test for metabolite test, there's no thyroid test, but we still have the pill factory through Dr. Tufts and then into Dr. Gelada for that period of time. You're telling this jury that that is, in your opinion, reasonable little drug doses that she was prescribed? Is that what you're telling this jury, sir?
That it was reasonable to prescribe?
Yeah, the drugs, one right after the other, and then stopping the SSRI, not weaning off, stopping it flat out. Is that reasonable?
Objection. Sustained, just as to form.
Is it reasonable, sir, in your opinion, to tell someone who's on an SSRI, such as Zoloft or Prozac, just stop it and we'll put you on something else, or should you wean it off?
In the case of the Zoloft and the severe insomnia, in my view, it was reasonable to stop it.
And then prescribe new drugs?
Well, insomnia was a significant problem, so as I recall, Ativan and Benadryl were prescribed to assist her with those symptoms.
Now, if somebody, is nervous because they have an exam coming up, or they just can't sleep because maybe they're worried about their job, there's a big difference between that and serious insomnia. Is that true?
Yes.
And Lindsay was suffering very serious insomnia, according to the medical records and her statements to her providers, right?
That's right.
And in fact, when Tufts increased the SSRI 25 to 50, she went 48 hours straight without being able to sleep, right?
That's in the record, yes.
And she went pretty much immediately to Tufts and complained about that and said, I can't sleep. It's 48 hours. I just can't sleep, right?
Yes, I think that was around the 21st of October.
And in your experience with dealing with terrorism and terrorist threats and things like that, would you agree with me that sleep deprivation is used as a torture?
It can be, yes.
And in fact, the side effects, if you will, of a person who's suffering from serious insomnia can actually lead to psychosis, can it not?
Yes, it's possible.
You're aware that while she's living in her house with her husband, Pat, and their 3 kids, that by all accounts, she was a happy mother, wife, friend, daughter, all of the above, right?
No.
So as the summer progressed, is it your understanding from Dr. Sadoff's investigation in this case that Lindsay Clancy and her husband, Pat, and their kids during the summer of 22 were not living their best life, enjoying life?
The summer was very good from Callan's birth really through much of August. Through the time that Patrick Clancy was at home, that first 12 weeks was really quite good.
And then it went sideways, right? She started having some concern about anxiety, right?
She did.
That brought her to Dr. Tufts' office. Oh, brought her to talk to Dr. Tufts on the telemedicine, right?
Correct.
And then she started getting her prescriptions, such as the SSRI at 25, SSRI increased to 50, 48 hours without sleep, went back to Dr. Tufts, more medications prescribed, right?
Yes.
Was she in rough shape in October of 2022 after dealing with Tufts for about 3 weeks?
She was certainly having difficulty, although the Benadryl and the Ativan were very helpful for sleep.
Okay. I'm just going to grab this item here. I'm just going to kind of hold it. In your investigation, you did look at the text messages and all the stuff that was on Lindsay's phone. Right?
Yes.
Her life was pretty much turned inside out, right? I mean, government got access to every text message she sent, right?
Yes.
Every email that she sent, right?
Yes.
Every memo that she wrote on her phone or on her computer or whatever, right?
Yes.
Every journal entry that she ever wrote during this period of time. We have it all, don't we?
Yes.
And in October 20th, sir, did you see this text where she texted her mother and said, Mom, will you please come up and stay with me a bit? I'm really sick. Something's wrong. I had horrible insomnia all night. I just don't know how I'm going to get through the day. I started to take medicine the doctor prescribed for anxiety, and I think it's made things worse. It's just really scary. And I don't... Did you see that?
Yes.
So she wasn't doing well in October, was she?
Correct.
And continued to see Tufts, right?
Yes.
Gelada, right?
Nurse practitioner Paul and then Gelada, yes.
Okay. Now, in your investigation of the medical records, would you agree with me that Lindsay was not running around from doctor to doctor to try to physician shop, to try to get drugs so that she could get high or use the drugs? That's not what she was doing, was it?
Ms. Clancy expressed concerns that she was not following a plan and that it would have been better for her had she tried to to stick with a plan.
Is that one sentence in all of the medical records where it makes reference to the fact that she said something like, I should have stuck with the plan? Is that what you're referring to?
Yes.
Okay. My question, sir, was Dr. Tufts, Dr. Paul, Dr. Gelada.
Nurse practitioner Paul and Gelada.
I apologize again. That's
right.
My bad. Nurse practitioner Gelada. Up to that point, bringing us into November, these people and other emergency room visits that she had, she was not going out looking to score drugs off of drug prescriptions. Is that fair?
Correct.
And she, in fact, looked up Tufts, but she didn't even know who Tufts was. She went online and Googled postpartum depression and found an expert. Isn't that right?
That's my understanding.
But she was only practicing for like a month or two. Was she, in your opinion, to a reasonable degree, a psychiatric certainty, an expert?
Objection.
Overruled.
It depends on the amount of training that she received, not just as a physician and a resident, but also in the area of women's health.
So the young lady goes online, Googles, trying to get help, goes to see the expert, Dr. Tufts, ultimately deals with nurse practitioner Gelada and counselor that worked in that medical field business, Letitia Dukes, I believe is her name.
Right.
And then she had the need to go to an emergency room and went to Mass General Hospital, right?
That's right.
And she was with her husband, Pat, right?
Correct.
And she had been complaining about lack of sleep, insomnia, right?
Yes, as I understand.
She had been complaining about inability to emote, feeling hollow, not myself, right?
Correct.
And a number of other complaints that were brought to the fore. And the hospital made a recommendation that she go to McLean Hospital, which is a locked ward mental institution in Massachusetts, and she chose not to do that, correct?
That's right.
So then what she did is went back to her home and immediately hooked up again, if you will, with Tufts, right?
That's right.
In December, one of the people at the South Shore perinatal unit advised her to go to a hospital that specializes in postpartum women. That would be Women and Infants Hospital in Rhode Island, right?
That's right.
And she went there like the next day, right after they called, right?
Yes, I think they fit her in pretty quickly. Was it maybe the 20th of December?
And her husband dropped her off for that day program, right?
That's right.
And she participated with the coloring, with the conferences, or with the discussions, and evaluations with the doctor, right?
Yes.
For about 8 hours. It was about an 8-hour day, right?
Something like that.
And on that day, in December 20th, she was turned away, basically, right?
I don't know that I would term it turned away.
Did they help her?
By Dr. Diaz's notes, but.
Did they help her?
Pardon me?
Did they help her?
They felt that another program might be more appropriate, either inpatient or partial hospitalization or outpatient, just based upon her concerns about medication.
And her concerns about the symptomology of postpartum depression, right? That's why she was there.
She was having depressive symptoms, yes.
Right, and that's in addition to, everybody wants to say GAD, 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 general anxiety, depression. This woman was there for treatment of postpartum depression, right?
She was there for treatment of depression. I was under the impression that most of the women who were in that program were much closer to had given birth to their children. And so in that respect, it was not the group that they served were much closer to that postpartum period, as I understand.
You're not going to say to this jury that because Lindsay was outside of the, let's say, 4-month cutoff, that she was not a good candidate for postpartum depression treatment? Is that what you told us, Jay?
No.
Oh, okay. I'm sorry. I thought you said because of the time frame from giving birth to the time that she went to see them.
I was just speaking about my understanding from the note from women and infants in terms of their decision-making.
Okay. And women and infants basically discharged her after about 8 hours, right?
Yes.
And her husband was up skiing, and then she contacted him, and he had to come down and pick her up and bring her home, right?
That's right.
And the reason that she was discharged from Infants Hospital in Rhode Island included a statement, RO, rule out issues regarding prescription medications, correct?
Yes, that's my recollection.
And she indicated that she was going to go right back to TOPS, right?
Yes.
And she did, didn't she?
Yes, as I understand.
And would you agree, sir, that every time a doctor said to Lindsay to do something, whether it was to make an appointment somewhere, whether it was to take another drug, any advice, that she was on it immediately? Is that fair?
She attended her appointments, yes.
Well, not just that, she attended them right away. She was told, for example, at McLean, you read those records, that she should hook up with her provider, and she did the very next day, right?
Yes.
Okay. So she wasn't avoiding seeing healthcare professionals, was she?
No.
And she was continuing to express concern about her state of mind. She felt that her mind, her brain was being damaged. Isn't that right?
That's right.
Those are in the records, right?
Correct.
And she felt that her brain being damaged was permanent, and she was never going to get better, right?
Yes.
She was complaining not just to her physicians, but she was complaining to people in her community that she was having intrusive thoughts, dark thoughts, suicidal thoughts, and homicidal ideation. She said that, correct?
The homicidal ideation, as I understand, was just voiced to her husband and her mother.
Just voiced? Is that what you just said? Just voiced? Is that like talking about the Red Sox? She's talking about homicidal ideation of her children.
Sustained. Next question.
I asked you about her complaints of intrusive thoughts, complaining to doctors, complaining to friends, complaining to neighbors, family about dark, intrusive thoughts of suicide and homicidal ideation. Didn't she?
I just don't recall that she complained of homicidal ideation to healthcare providers.
Finish answering.
I think, Doc, you finished? Did you finish the answer? Doctor, did you finish that last answer?
Sure.
Okay. All right. Next question.
So we'll put homicidal ideation aside for a minute. Would you agree that for that period of time, short as it may have been in her life, November into December, that she was reaching out to people that would listen to her for help?
Yes.
Would you agree, sir, that she would tell, for example, neighbors or friends with the Learning Sprouts School, her family, her doctors, that she was having these dark, intrusive thoughts of suicide Yes or no?
Did you ask whether or not she was telling her children's teachers at Learning Sprouts?
Anyone that she would come in contact with at Learning Sprouts, whether it's another mother, whether it's a friend, whether it's a teacher, whether it's an administrator, whether it's somebody that just watches the kids in the playground, did she tell anyone that she had dark, intrusive thoughts to your investigation?
Those people that you named, I wasn't aware that she informed them about that.
When someone says, with her history up to this point in December, that they're having dark, intrusive thoughts to a professional, in your opinion, sir, to a reasonable degree of medical certainty, does it make sense that the professional should ask the person whether or not these are voices that they're hearing in their head, or whether or not they are just thoughts that they're having?
Certainly exploring that is important.
And would you agree with me, sir, that when you have a young woman that, again, by all accounts, done nothing wrong in her life, exemplary citizen, has these issues and sees the doctors that, to a reasonable degree of medical certainty, a physician should do a little bit more than asking, do you have a plan? I mean, is that accepted practice, just to say, do you have a plan? And if they say no, you're okay.
I wasn't aware that that was the only question.
Okay. She was also told that counsel had asked you yesterday about other recommendations that were given to her by women and infants, and that you said that she did not follow through on that, but she did see Dr. Tufts pretty much the next day, right?
That's my understanding, yes.
Okay, and she said that she was going to go see Dr. Tufts the next day, right?
Yes.
And just to mention, before I forget it, the Lamictal, I think you mentioned to the jury that she had a prescription for Lamictal that she was able to fill, right?
Correct.
But she didn't take it, right?
That's right.
And then Tufts told her that she was going to, she meaning Tufts, was going to give her a script for Lamictal, and she said, no, I already have one, right?
It was Nurse Gelada.
Okay, sorry.
She had gotten the prescription and filled it from Dr. Tufts. And Nurse Gelada, when asked about the Lamictal, was very favorable about it and said, yes, that's great. That would be great.
Sir, I know. You want to tell me that it's a wonderful drug. Did she tell nurse practitioner Gelada, I already have a script, I don't need it?
Yes.
Among other things, when people are in trouble and they're having dark suicidal thoughts, whether or not it's voices in their head, whether or not it's thoughts that they can't go on anymore, they can't live life, they have to kill themselves, many times they're told to call suicide hotlines, right?
Yes, Aspire.
Aspire. What is Aspire?
I don't know what it stands for, but it is a hotline that Ms. Clancy called twice because of her suicidal ideation.
When did she call Aspire saying that she had thoughts of killing herself?
I can't recall specifically.
But she did call them not once but twice and told them. So she complained and told them that she was going to kill herself, right? Twice. Right?
She spoke to them about suicidality.
So here's a young woman with all of what she's been through who now is to the verge of killing herself and reaches out to people that her health care providers told her to call for help, said that she was going to kill herself, and what did Aspire do?
As I understand, they redirected her to her provider. They did not make a decision to hospitalize or to recommend hospitalization.
They didn't make a decision to do anything.
Objection.
Yeah, so you could form that as a question, please.
Did you read the records dealing with Aspire? Did they do anything other than tell her, no, you're not someone that we can help?
I know that they were not responsive to her suicidality because she did not indicate that she had a plan.
And did you read a transcript or listen to a tape, or how do you know that?
I recall it someplace in the documents, it being referred to, but I can't tell you exactly where.
So this, sir, obviously is a murder trial, and you are a witness for the government, and you've indicated that you've read the records. You just told this jury that in the conversation that she had with the people from Aspire that she expressed suicidal ideation and was asked if she had a plan. Where are you getting that from?
I can't tell you exactly within the records.
How about the second time she called Aspire? Why would she call Aspire again if they wouldn't help her the first time? In your opinion as a psychiatrist? Looking for help?
Continuing to seek help.
And yet again, she didn't get any, did she?
That's my understanding.
To a reasonable degree of psychiatric certainty with treating the patients to the extent that you've told this jury that you have, what kind of a devastating effect would that have on a person who's ready to kill themselves that's called Aspire hotline twice and has been turned away?
Objection.
Overruled.
It could have a very serious effect.
And after being discharged from Women and Infants Hospital and reaching out to Aspire, you'd agree with me that one of the concerns that the doctor at Women's Hospital in Rhode Island had is the medication that she had been prescribed by top-end nurse practitioner Gelada, right?
Correct.
And that's one of the reasons that they could not treat her. It wasn't just that, no, we don't think that you're postpartum depressed. We just think that there's a complicated overlay involving the medications that you've been prescribed, right?
Yes.
And these medications obviously included selective serotonin reuptake inhibitors, right?
Yes. Prozac and Zoloft.
Right. And one of the things that a doctor would be concerned about, especially with a woman who's had a baby and has stopped breastfeeding the baby, is the effect that that may have on the woman, physically, mentally, emotionally, when they stop breastfeeding a baby, right?
Yes.
And you've heard of gamma aminobutyric acid, otherwise known as GABA, right?
Yes.
And can you tell us, please, what that is, sir?
I'm sorry.
Can you tell us, please, what that is, sir? What is GABA?
I believe that you're referring to Lyrica.
No, I'm asking about the actual acid in the person's system, their blood, that is gamma amina BULRYC acid. It's got nothing to do with lamictal. It's got nothing to do with Seroquel. It's got nothing to do with the drug industry. This is in the body. When a woman stops lactating, a woman stops breastfeeding.
Yes.
There is a physical effect on the person, the body, right?
Yes.
What is that effect?
It depends on the individual. There's variable responses postpartum, and as I understand, she stopped breastfeeding around October, by October 21st or so, when the Ativan was started.
Would you agree with me, sir, that the GABA, make it easier to type, is basically affects, its primary effect is on the neurotransmitters in the brain, right?
Yes.
Okay. That sounds pretty complicated. Neurotransmitters, I mean, is that like where you have a spark plug on a motorcycle and you can actually gap it and get it to kick over? It's a neurotransmitter in the brain? That sounds like it.
Well, yeah, it's more complicated than that.
I figured.
Obviously.
But nevertheless, it's still basically, you're talking about the actual organic matter of the brain, right?
Yes.
And would you agree, sir, that when a woman is pregnant, that there are progesterone hormone surges during that pregnancy?
Yes, there are hormonal changes.
Their hormone doesn't just change, it can actually surge, and it can be quite impactful to the person, right?
Yes.
And would you agree with me, sir, that one of the metabolites of progesterone, which has been unleashed when a woman is pregnant, with the progesterone hormone surging through their body, that you have a metabolite that actually enhances or increases the GABA activity of the neurons in the brain, right?
It can, yes.
And what is that metabolite, sir, that increases that activity in the very organ of the brain?
I can't tell you.
Is it a allopregnanolone? If you know?
No.
No, it's not, or no, you don't know?
I don't know.
Immediately after a woman has a baby, would you agree, sir, that the progesterone that we just talked about and the allopregnanolone that you don't know about drops precipitously according to the medical treatises, right?
Objection.
If he knows, he can answer that.
Yes.
And what does that mean, sir? Tell me, when it says that the progesterone and the allopregnanolone in the body drops precipitously. What does that mean, precipitously?
That means rapidly.
And a sudden drop, sir, you would agree, has a significant potential of causing serious GABA dysfunction, right?
That certainly would be possible.
Do you know that, or are you just agreeing with me?
I'm agreeing with you.
Okay. Do you want me to keep going?
Want to take a short break?
I don't care. I'm just saying that.
Yeah. Why don't we take the morning recess at this point? All right.
Cora, all rise, please. Jurors, kindly close your notebooks. Please on the chairs. This way, please. others have exited the courtroom.
All right, Counsel, can I see you at sidebar, just briefly? Dr.
This court is back in session. You may be seated.
Your Honor, for the purpose of the record, we return back to the trial of Commonwealth versus Lindsay Clancy. All parties are present and will be adjourned.
All right. Counsel, we ready for the jury?
Yes, Your Honor.
Yes.
All right.
Court, all rise. Jurors entering. This court's now in session. Please be seated.
Your Honor, for the purpose of the record, we return back to the trial of Commonwealth versus Lindsay Clancy. All parties are present, including the defendant and including the 18 jurors.
All right. Counsel?
Thank you, Judge. Sir, when we left off, I believe the question was that, and you agreed, the sudden drop can cause significant GABA dysfunction. Recall that question where we broke off talking about the,
Yes.
The gamma? And you're familiar with the concept of, in that regard, talking about the gamma-aminal butyric acid and its effect on the progesterone and its effect on the brain synapses, is referred to as breaks, B-R-E-A-K-S. You've heard of that term, right?
No.
You aware, sir, that when you get to the point where you have that precipitous drop in the progesterone and the allopregnanolone dropping precipitously, that in fact it constitutes and causes significant neurotransmitter malfunction, referred to as broken brakes?
I'm not familiar with that term.
Can you tell me what a neurotransmitter in the brain is?
You're asking what is a neurotransmitter?
Sure. I don't know.
Neurotransmitters function in the brain and have responsibility for not only aspects of mood, but also psychosis. Dopamine is a neurotransmitter that is significant in terms of psychosis. When it's too high, we need it. And the neurotransmitters function in a number of different ways, number of different pathways. When we think about psychiatry, we really think about the mesolimbic pathway and not just dopamine, but also serotonin, norepinephrine. And so depending on the disorder, there are different medications that can be helpful in treating those disorders. So really, from the standpoint of psychiatric illness and brain dysfunction, medication can be very helpful in regulating the neurotransmitters and difficulties.
Have you heard of the broken brakes hypothesis as it relates to the impact of the precipitous drop of progesterone in the enhancement of the GABA activity? Have you heard of that concept?
No.
Would you agree, sir, that when a woman is in that position of the precipitous drop of the progesterone after ceasing the breastfeeding activity, the enhancement with the GABA...
You mean prolactin?
Prolactin. The enhancement of the GABA activity, that that would be a dysfunction in the brain, right?
Certainly, mood symptoms can be significant.
Would you agree, sir, that the dysfunction in the brain caused by those two items is consistent with intrusive and hard to control thoughts and highly impulsive, uncontrollable behavior? Would you agree with that?
I would say it's possible.
And that would relate to the capacity of a person to conform their conduct. If, in fact, because of the GABA and the progesterone and all that we just talked about, the intrusive, hard-to-control thoughts and highly impulsive, uncontrollable behavior would address itself to the issue of capacity to conform one's conduct, right?
No, I mean, it depends on the timing. If you're talking
Is the answer no?
at 8 months,
Yeah, hold on. You gotta let doctor finish. Did you finish that answer?
yes.
Okay. All right, go ahead. Next question.
So, did I hear you say that Patrick is the source, the third-party collateral source of Lindsay saying, I tried to kill myself? Is that what you said? Let me rephrase it for you. I mean, did you tell the jury about an hour ago or so that
When her husband found her on the ground?
Yeah,
Yes, or something to that effect.
something to that effect, okay. And did you listen to the 911 tape when Patrick was actually speaking with Lindsay as she's laying prostrate in the snow on the ground with the broken neck and the slashes and the slits?
Yes, I did.
Did you hear her response to Patrick's comment, what did you do?
No.
Did you hear her respond to anything other than what would be described as guttural grunts?
Not on that call.
So when this conversation occurred, and this is the conversation that you're talking about, where she said, I tried to kill myself, kids are in the basement, he then goes into the house, right?
Correct.
All right. So now we have the EMTs and people are helping her out. We've seen the medical records. You know what the injuries were. You know the damage to her throat. You know the damage to her thyroid, right?
Yes.
And is it your testimony to a reasonable degree of doctor certainty that a person with those injuries, with the prescription drugs that were crushed up, that she consumed, with a broken neck, would be able to have a conversation?
Based on the witness testimony from her husband, yes.
Okay. So let's put the witness testimony from Patrick aside for a minute. And you listen to the 911 call. Are you telling this jury that she had a conversation that you could discern what she was saying?
Not on the 911 call.
No. Would you agree that they were all grunts?
Yes, from what I heard.
So Patrick goes in the house, relates the fact that he found the children, and you told the jury that his office door was closed, is what he said. Is that right?
Yes.
Where did you get that from?
I believe Patrick told me that.
Is that in your report?
Yes.
And when he told you that, when was that conversation that you had with Patrick?
When I interviewed Patrick Clancy.
Okay. So you read the grand jury minutes, right?
Yes.
You read the police report, right?
Yes.
You know that Patrick went up the stairs, and when he went up the stairs, the door was locked, right? Meaning the bedroom door, not the office door.
Correct.
And then he was able to open the door, right?
Yes, with a key.
And there was blood on the doorknob, right?
There was blood in the room on the
Describe the room
on the floor.
Certainly, you already talked. We'll talk about that. But there's blood on the doorknob, right? Was there blood on the doorknob? If you know,
I don't recall.
do you recall there being blood drops in the area of the door itself, like where you have the threshold? But what appeared to be blood, because nobody tested it, we don't know what it is, but it appeared to be blood.
I don't recall the specific. I know that there was blood that was observed.
Okay. And you would agree that there was a lot of blood drops, drips on the mirror, drops on the floor, drops on the nightstand, right?
That's my recollection.
And you looked at the photographs in your investigation and looked at the testimony, third-party collaterals, as you testified yesterday, right?
Yes.
And you told the jurors that one of the things that was of interest to you is the fact that there was a glass or a wine mug or something that had crushed narcotics or I think he used the word antipsychotic drugs crushed up inside that cup. Do you remember that?
Yes.
Okay.
Wine tumbler.
Thank you. How do you know they were antipsychotic drugs?
I don't recall saying that they were antipsychotic drugs.
Oh, did you say they were drugs?
I thought I said medications.
Medications. All right, so drugs, medications, and they were crushed up?
There was evidence of powder on the tumbler that Patrick told me about, and I went back and looked more closely at the photographs and saw that.
Did you look more closely at the NMS laboratory or the state police crime laboratory or any testing that was done on the powder?
Yes.
And was there a report that said that indeed it was crushed up medication?
They wouldn't.
I mean, there is.
They didn't indicate whether or not they were pills or.
Did they ever? I'm not asking about pills or powder. Did they ever test the residue?
Not that I'm aware of.
So how do we know that that's even drugs or medications or whatever word you want to use?
It was Patrick Clancy's observation.
So basically, when you're testifying, sir, and you're waxing on about all of the facts of the case that you took into consideration prior to your opinion for the DA in this case, you're getting a lot of it from Patrick, is that right?
That aspect he brought up to me, yes.
Okay. So the crushing of the pills, was there a pill crusher found in the bedroom?
Not that I'm aware of.
Was there any residue found anywhere in the bedroom?
Not that I'm aware of.
So if someone's in a psychotic state and they're going to kill themselves and they're taking the pills, yesterday you said the fistful of pills, and then the DA said, after a painful questioning, that they were crushed, and you agreed that they were crushed, wouldn't there be a residue?
A residue?
Yeah, you know what a residue is, right?
Yes.
Was there a residue on the table, on the nightstand, anywhere?
Not that I saw.
So there's no pill crusher, right?
Not that I saw.
There's no investigation by the police to determine what was in that powder, right?
Not that I'm aware of.
There's no indication that there's any residue on or in the actual nightstand next to the bed, right?
Not that I'm aware of.
Does it seem appropriate, sir, that a person would be in a psychotic state after slashing their wrist and slicing their throat and ready to propel themselves out a window would neatly put the bottles into the drawer of the nightstand? Or would they just scatter them around the bedroom floor, not caring?
I'm not aware of the exact sequence of the events in terms
Well,
of.
if I tell you, sir, that a couple of days after this incident, I went into the home with Patrick, and I was able to locate in the bedroom, right next to the bed, with all the blood all over the place, this drawer, and inside this drawer would be a lot of medication bottles. Does that refresh your memory on your investigation as to what happened to the bottles? They're all empty.
Yes.
Okay, so how'd they get in the drawer?
How did they get in the drawer? I don't know.
You can fingerprint them, right? Did anybody do any testing at all in this investigation? If you know. You told the jury yesterday you read all the stuff, grand jury minutes, police reports, lots of witnesses.
Yeah, I did not read that.
Is it your understanding, sir, that a person can be in a state of psychosis and I guess misremember something?
Yes,
Or have a false memory?
it's possible.
Did Lindsay tell you that she slashed the screen with the big turkey knife?
I'm sorry, can you repeat that?
Yeah, did she tell you that she slashed the screen with the knife before she went out the window?
Yes, that's what she told me.
But the screen wasn't slashed, was it? Do you think she was malingering and lying to you at that point, sir, when she told you that?
No.
Because one of the things you told this jury is that what stood out to you is, I think you made reference to the fact that Lindsay betrayed her family by misleading her family. Remember saying that to this jury yesterday, sir?
Portrayed?
Betrayed is what you said.
No, I said portrayed.
So Lindsay portrayed and misled her family, is what you said to the jury?
Yes.
How'd she mislead her family?
Well, in text messages, for example, in the days prior to the event, her parents had visited over that weekend, and the communications that she was providing did not give a sense of her state of mind regarding suicidality.
Are you kidding me? They stayed up in their house to help them.
Sustained. Next.
They stayed at the house, didn't they?
Yes.
Why did they stay at the house?
I'm sorry.
Why did they stay at the house?
They were visiting.
They were staying at the house. They weren't just visiting.
Objection.
Overall.
Sleep over?
As I understand.
Okay, as you understand. How long did they stay at the house and sleep over?
I think they came up for that weekend. They weren't there constantly.
No,
They came back and forth.
back and forth. Well, they stayed about 4 days, 3 nights. They stayed continuously and stayed at the Clancy home. You knew that from your investigation, right?
Yes, that's my
yes?
recollection.
The answer is yes, right?
Yes.
Okay. So they're staying at the same time. You're telling this jury that she's sending text messages basically saying, I'm okay, I guess. Is that right?
Following their departure, there were the photographs that Lindsay Clancy sent to her mother.
She didn't send her mother photographs showing that she was smiling or happy with her family, did she?
I think there was a photograph of her and the children by the snowman.
No. Is that a bad thing to do that and send a picture of you with your kids making a snowman to your parents?
No.
Is that something, in your opinion, Dr. Sidoff's opinion for the district attorney, that a person who is involved with postpartum psychosis, postpartum depression, wouldn't take a picture of the snowman and their kids, send it to their mother?
Given the prior text that you showed to her mother in terms of being in terrible distress, that she was able to do that, that was not what happened when she sent the picture with her children and the snowman, and so did not raise concerns from the mother, as I understand.
Did you talk to the mother?
Pardon me?
Did you talk to the mother?
No, I tried to.
Did you review police reports or statements? You tried to? How'd you do that? What'd you do, call her up and say, I want to talk to you?
No.
Did the district attorney call him up?
I asked Ms. Clancy who would be good for me to speak with, and she said her husband and her family.
Okay. So based on that, what did you do?
I contacted the district attorney, and I...
Which one? Which one of these two?
Ms. Sprague.
Ms. Sprague. Okay. You spoke to Jen Sprague, and what did you say to her?
Sprague.
Was it?
Attorney Sprague.
You spoke to Jen Sprague, and what did she tell you?
Attorney Sprague.
She told me that she would reach out and attempt to see if I could interview Mr. Clancy and Ms. Clancy's family.
Okay. So did you do that? Did you reach out to her mother?
Did I reach out?
Yeah.
No.
Okay. Did someone tell you that she wouldn't speak to you?
Yes.
And when was this, sir? About 2 months ago?
It would have been probably June 5th.
This is August, right?
Pardon
This
me.
is August. We're in August right now, right?
Yes.
You called to speak to the mother in June, right? Yes? Come on.
Yes.
Okay. And when you called the mother, did she say,
I did not call the mother.
Okay, so the
I did
answer
not
is you
call
did
the
not
mother.
call the mother. Who told you that you couldn't talk to the mother?
Ms. Sprague.
Attorney Sprague, please.
Right. Attorney Sprague.
Now, when Attorney Sprague called you and said you cannot talk to the mother, did it ever occur to you to reach out to me? You're being objective and all.
No.
Did you know, sir, that Lindsay had signed repeatedly every and any HIPAA form that was needed by the DA or other cops to get access to every single medical record that she had? Probably going back to when she was in grammar school. Did you know that?
I know she's been open to it, and she told me that she would like for me to speak with them.
Right. And she's been open to pretty much anything and everything that was asked of her as far as signing documents, getting medical records, doing interviews, videotaping, making appointments to talk to guys like Mac and Helbrun and you in Tewksbury Hospital, right?
I'm sorry, can you repeat the question?
All of your investigation, sir, led up to the fact that you were going to meet with Lindsay 2 months ago, 2 months prior to our beginning this 5-week triple murder trial. Is that fair?
That's true.
And you told this jury that you wanted to establish a rapport with this kid?
Yes.
Do you think for 1 minute, when you're trying to put her in jail for her life, that she
Objection.
wants to talk to you and have a rapport?
Next question.
Did you establish a rapport?
I believe so.
She was cooperative.
Yes.
She was polite.
Yes.
She was pleasant.
Yes. And I asked her at the end if there was any question that I had asked that made her feel uncomfortable, and she responded in a positive way.
Okay. One of the things that you told the jury is that you felt that she was malingering, or basically lying. I guess you were telling the jury, in your opinion, that she was making stuff up to make herself look like she's crazy when she killed the children. Is that what you told the jury?
I didn't use those words.
No. You're a little more finesse than I was. But nevertheless, sir, you're talking about malingering, right?
Yes, the statements about the auditory
Answer is
hallucination.
yes. Excuse me.
Yes.
The answer is yes. You were talking about malingering is my question. Yes or no, right? That's all.
Yes.
Okay. And when you're talking about malingering, sir, basically that would be when a person finds it in their interest to basically exaggerate or lie to an investigating psychiatrist, right?
Correct.
And that would be because it's in their interest, like I want to pretend that I'm crazy so a jury thinks I'm crazy and I don't have to pay for a crime. That would be in a criminal sense, right?
Yes.
Workman's comp cases, you know, a guy gets hurt in the truck and then they end up having interviews by guys like you to make sure to see if, in fact, they're legitimately hurt for a workman's comp claim, right?
Yes.
Or a civil case, like an auto accident, right?
Yes.
And there are tests that can be administered to people to see, from a psychiatrist standpoint, whether or not there is objective indicia of the fact that the person is indeed malingering.
Yes.
And what are those tests?
Well, I'm not a neuropsychologist, but there's a test called the SIRS, also the TOMS test of memory. So there are certain tests that can be given by neuropsychologists to assess malingering about certain aspects, certain issues.
You've also heard, I imagine, of the MMPI, which is the Minnesota Multiphasic Personality Inventory Test, right?
Yes.
And that's one that has different scales that you can examine to determine if somebody is lying or malingering or exaggerating or anything like that, right?
Correct.
And you know that Dr. Helbrun administered that very test to Lindsay about, I don't know, 2 months before you got there, right?
Yes.
Which would be about 4 months from now, where we stand now, right?
Something like that.
And would you agree, sir, that even though it would have been perhaps better to actually meet with Lindsay within the first 6 months after the incident, or a year even, or maybe even 2 years, but nevertheless, it still has reliability and validity, does it not, when it's administered to her?
The MMPI does, yes.
Okay. And you know, sir, that she, in fact, had no impact on the scales at all, with the exception of likelihood of suicide.
Yes, that's my understanding.
Indicating that, as far as that test that was administered to her by Dr. Helbrun, did not have any evidence at all. This kid was lying, exaggerating, suppressing anything. She was being truthful, right?
Objection.
Overruled.
About the questions that were on the MMPI, yes.
And those questions, sir, pertain to personality traits, they pertain to her recollection, they pertain to all of the investigation that Helbrun was conducting, right?
No.
Okay. So, when the tests were administered and the results were provided, would you agree with me, yes or no, that specifically the test indicated that she was not malingering?
Yes.
Okay.
Correct.
You mentioned one of the other things that you were concerned. Oh, by the way, would you agree with me that Dr. Philip Resnick, as you indicated, is like a world-renowned person on filicide, or the killing of your children? He's also a person that is in the forefront pretty much worldwide on malingering, right?
Yes, he has written about that.
He's done more than write about it. He's basically given hundreds of lectures and many, many, many learned treatises, all about people that lie to psychiatrists to try to get away with something, right? Right?
Yes.
Okay. And you know, sir, that Dr. Resnick examined Lindsay, and one of the first things that he did was determine whether or not, in his opinion, she was malingering, lying, suppressing, exaggerating, or doing anything like that, right?
Yes.
In his opinion, sir, when you read his report after all the testing of his examination, is that she was not lying to him at all. Isn't that right?
Yes.
One of the things that you referenced, sir, was you felt that Lindsay was lying about standing at the refrigerator and making chicken McNuggets or whatever, and carrots or peas or something. And you felt that that wasn't right because the child had already had a bowl and was eating, I think you told the jury, chicken nuggets and vegetables or something like that, right?
Green beans.
Green beans. Have you looked at the photograph, sir, that's in evidence in this case about that bowl?
Quite some time ago.
Does that show any residue of chicken nuggets or green beans in the bowl?
Not that I recall.
No, it shows like sliced up residue of a cucumber, possibly a carrot, like vegetables, right?
Not that I recall.
So there are 3 kids, one of which is an infant who obviously pretty recently got finished breastfeeding, is on the bottle, so he's not going to eat chicken McNuggets, right?
Right.
So we have 2 young children that have to be fed, correct?
Yes.
You have 2 young children that Lindsay indicated that she was at the refrigerator getting the chicken and the vegetables so that she could feed the kids, correct?
Yes.
Told you that she would not give the kids chicken McNuggets and vegetables in a bowl, that she would have a plate, right?
Not necessarily.
So when she was at the refrigerator, sir, it's your understanding that she was not being truthful? Telling you that? Is that what you're telling the jury?
I think what I said was very inconsistent with what she had told Dr. Spinelli.
So when she's at the refrigerator and telling you, your interview, I know you imported Dr. Spinelli's report, you imported Dr. Resnick's report, you imported Dr. Zeisel's report. When you were talking to Lindsay, did she tell you she was getting food for the kids out of the fridge?
That's my recollection.
Now, with all of the understanding in your testimony, sir, about the voices, correct me if I'm wrong. You're telling this jury, in Dr. Satop's opinion, based on your experience and all of your writings and everything, that when one hears voices, they would be internal or external? To be legit.
They can be either.
Really? I'm sorry. I thought you said that they had to be a particular type, like not internal. If they're internal, they're probably lying. But that's not true. I'm wrong? The voice
that Ms. Clancy told me about during the time of this event, she said was external.
Okay. And is that consistent with your understanding, sir, of the research on auditory hallucinations?
Well, some auditory hallucinations can be internal.
So
for people who are psychotic.
And you were aware, sir, that Philip Resnick, Dr. Resnick, did publish the article in the International Journal of Law and Psychiatry in 2014 in conjunction with Simon McCarthy-Jones. You're aware of that?
Yes.
Treatise, yes. And would you agree with me, sir, that in fact, just if some doctors might feel that hallucinations auditory must originate from the exterior as opposed to interior, would you agree, sir, that in this article, claim number 1, doctors may say, voices are typically heard as coming from inside the head, with the corollary that voices heard as coming from outside the head are atypical? Would you agree with that?
That was not my recollection of the research. That
okay.
I understood that it was a minority of.
No. Excuse me. It doesn't matter what you.
Oh, hold on. Good. Next question.
I'm going to approach you with the article. We've already established. You know who authored it. Right into it. All in. Okay.
It was quite some time ago.
Sure. Let me put your papers over here just so I don't knock them over. So, if we can share that.
Do you want me to say it?
No, I want you to share it. Put it right here so I can look at it. Okay. All right. Would you agree, sir, that it says voices are typically heard? This is a claim number 1. In other words, doctors would feel voices are typically heard as coming from inside the head, with the corollary that voices heard as coming from outside the head are atypical. Did I read that right?
Yes.
Okay. And what does atypical mean?
Atypical means unusual.
Right. And this article is saying that there are psychiatrists that feel that voices heard outside of the head, auditory hallucinations, are indeed not legitimate. Is that fair?
That was the old original way of thinking. That was the way it was taught at one time. That they had to be external for someone to actually be experiencing psychosis.
Okay, so we agree then, as Dr. Resnick indicates, that the research evidence does not support the claim that internal located voices are emblematic of genuine AVH,
Auditory verbal hallucinations.
and externally located voices are atypical. He cites a particular word, correct?
Yes.
For example, he then says, the largest study on this question Matthew Jones was in 2012. That's what you're referring to as the old research, right? Oh, whenever you were in med school, we talked about that too. That would have been.
Yeah, I was speaking about very old.
Okay. Basically found that of 199 psychiatric patients, 81% who have been diagnosed with schizophrenia, 38% heard both voices coming from inside and outside their head. Did I read that right?
You did?
So when Lindsay indicated to you that she indeed heard a loud auditory hallucination, voice, deep male, commanding her to do what she told you, that was external, correct?
Yes.
And you don't have any issues with that. In other words, that is very likely could be legitimate.
Yes.
Okay. Now, if you take a young woman who, as the evidence has shown, is suffering with her medical condition or psychiatric condition and seeing doctors and being prescribed medications and reaching out to people for help and suicide hotlines and people down in Rhode Island and McLean Locked Wards Institute. If I hold an opening statement, sir, would you agree that in her efforts to maintain control, she, meaning Lindsay, withheld.
Form the question?
Yeah, if we could approach.
Sure.
Would you agree, sir, based on your investigation, police reports, statements of witnesses, grand jury, photographs, videos, interviews of Lindsay, review of witness statements, all of that you told us yesterday that you reviewed, that in fact on January 24th of 2023, Lindsay made a calculated decision. She was a woman who no longer liked the life she thought she wanted. It was getting harder and harder for her to control, and when she saw the opportunity to escape, she made the selfish choice to take it, and to take Cora, Dawson, and Callan first, before attempting to take her own life. Continuing on, sir, she chose to manipulate her providers, seek out a quick and easy fix when she was feeling depressed and anxious, and when she didn't get what she expected, she chose the alternate route. She would seek a different doctor. She would change medications after days. She disengaged from treatment that she didn't like the plan, and after only 4 months in treatment, she made a choice, a deliberate and intentional decision that she did not want to try anymore. And because no one could take care of her kids the way she wanted them to, she had to take them with her too. Would you agree that the evidence, in your opinion, supports that contention, sir?
Well, there's a lot in that.
Yeah, it is. Do you agree that it would support your contention, sir, or it would not?
I think that statement that you read really minimizes what she was going through.
Okay. All right, thank you.
Attorney Sprague?
Thank you, Your Honor. Sir, you were asked during cross-examination about your work as a forensic psychiatrist for the Bureau of Prisons and for the prisons in Virginia. And about that work and kind of minimizing what your experience was there. What was your work there? What did that entail?
Well, I continued to work there, and I continued to teach students in that system. Seeing patients who are inmates in a number of different facilities, men's and women's facilities over the years, and doing assessments, evaluations, making determinations about treatment and the like, gathering information. So really treating these inmate patients as patients who have significant mental illness and really require the best treatment that we can provide in the system.
And during the course of your many, many years working in that system and treating these patients, have you treated patients with psychosis?
Yes.
And does that include treating women with psychosis?
Yes.
And how often have you done that?
I'm going to object. I didn't ask about it. He said two already. He's already said twice.
Overruled. She may have that. Go ahead.
Since 1992,
Yes.
so 34 years.
How many patients have you treated in the prison system, women patients dealing with psychosis, approximately?
Several hundred.
And are there certain common signs or symptoms that these women display who have psychosis?
Yes.
And what are those?
Well, some have delusions, fixed false beliefs about certain things, though they can present as being psychotic that way. Also, they can present with hallucinations, what we call perceptual disturbances, and generally they are, in most cases, auditory hallucinations, auditory verbal hallucinations. And they also can present with disorganized thinking, having words, making up words that have special meaning, really having a great difficulty communicating.
And you also mentioned that you all worked for a state hospital for, I think you said 15 years, is that correct?
Correct.
And did you treat patients with psychosis during those 15 years?
Yes.
And did those include women with psychosis?
Yes.
And in terms of your treatment of women with psychosis, were you responsible for diagnosing them with their underlying mental condition?
Yes.
Diagnosing psychosis as being one of their symptoms?
Correct.
And then treating the underlying condition and the symptom of psychosis for those women?
Yes.
And you did that for approximately 15 years, correct?
Yes.
And you mentioned two specific patients, females that you dealt with postpartum depression or postpartum psychosis. Do you recall that?
Yes.
And what did you learn from treating those two patients?
So those are the two patients that are mentioned in the case reports.
Which case reports?
The case report about postpartum psychosis that was written.
On the medication interaction?
Yes. Are you asking how those patients presented?
Yes.
Okay. There were, as I recall, it's been a while since I've looked at the paper, but one was an 18-year-old woman who had delivered her child and had decided not to take, or that she did not want to breastfeed. And so in those days, this medication, bromocriptine, also called Parladel, was given. And we found that within, I think, just a couple of days of the time that she was given this medication, she became convinced that she had to kill her child. And I believe that she was experiencing auditory hallucinations, and she was so distressed about that that she wanted to kill herself and was suicidal. And that was how she was brought to our attention. In evaluating her, we removed the Parladel, the bromocriptine, and she responded and resolved her symptoms, her psychotic symptoms, and we were able to discharge her back to her family. The other case, I believe, was another female, a bit older, maybe mid-20s, and she was also given this medication and also became psychotic. For her, it was more a manifestation of mania. She was hypersexual with her husband. She, I think, was quite hyper-religious, and she was...
Doctor,
sorry.
in terms of her delusions, those were more of religious delusions?
Pardon me?
Her delusions regarding her child were religious delusions?
Yes, I believe so.
Okay. And once that medication was removed from that woman, did her symptoms subside?
Yes. I think in that case, she was also given, she was so disruptive on the ward, taking her clothes off, et cetera, that she was also given antipsychotic medication for a period of time, and her symptoms resolved.
And going back to the first patient that you described, you said that she had voices instructing her to harm her child. And was it as a result of her feelings of guilt for about those thoughts and voices that she was suicidal?
Yes.
So she wanted to kill herself instead of killing her children, correct?
Yes.
Now, you were asked by Attorney Reddington about your curriculum vitae and focusing in on terrorism, and is that your sole focus? And you said no. What has been your focus over your career?
Well, from the time that I finished my residency, I've been very interested in public psychiatry. And so upon realizing the seriousness of mental illness within the prison system and the value of teaching psychiatry to students within the system, I began doing that while I was also doing work with the state hospitals, seeing patients, whatever. So I would say that of all the things that I do and consider myself, what is most important to me is working with patients, and it's the value of also being with students and having them learn from these patients is going to make them better doctors, even if they don't choose to go into psychiatry. So I see my identity actually as a clinician, and I have patients I'm scheduled to see. I was supposed to see some yesterday, and also I'm going to see patients on Friday.
And Doctor, defense counsel asked you about the onset of postpartum depression and postpartum psychosis, and you had said that the DSM-5 lists postpartum onset within 4 weeks, correct?
Correct.
And he asked you about other organizations going up to approximately a year, correct?
That's right.
Are you aware that the World Health Organization has a clinical descriptions and diagnostic requirements for behavioral and neurodevelopmental disorders that has a section on mental and behavioral disorders associated with pregnancy, childbirth, or the puerum, P-U-E-R-P-E-R-I-M, which does that mean during or after birth?
Yes.
And that in that section by the World Health Organization, they state that mental and...
Objection. She's not going to read that to him, and then he's going to agree with it. She can ask him if he's read
Well,
it.
let's hear the question first, and then I'll assume there'll be an objection.
Are you aware that in that section it states that mental and behavioral disorders associated with pregnancy, childbirth, or the puerperium are syndromes associated with pregnancy or the puerperium commencing within about 6 weeks after delivery?
Objection. Overruled. I'll allow that. If you know that, Doctor.
Yes.
Okay.
And are you also aware that there's a section talking about mental and behavioral disorders associated with pregnancy, childbirth, or the puerperium with psychotic symptoms that says onset of a syndrome involving significant mental and behavioral features occurring during pregnancy or the puerperium, i.e. up to about 6 weeks following delivery, is required for diagnosis?
That's my understanding.
And that's from the World Health Organization, correct?
Yes.
Now, you were asked about whether blood testing would be appropriate for a patient, and you said that it would depend on the history of the patient, the symptoms, the medication. Do you recall that?
Yes.
Okay. Did you see anything in the records about Lindsay Clancy that would have required blood testing?
No.
You were also asked about thyroid function and how sometimes you might want to test thyroid function in a postpartum woman. Do you recall that?
Yes.
Do you, are you aware that, reading from Exhibit 222, I believe, that Ms. Clancy's thyroid levels were checked when she visited the South Shore Hospital emergency room on November 16th, 2022, and her levels were within normal limits?
Yes.
I just moved to submit this page from Exhibit 222, showing the thyroid levels.
All right. So that's in. It's just a follow-up of a sheet that's in. I'll allow that.
And doctor, just for the jury to know, in that page that's just been marked in as exhibit, the thyroid levels would be marked by TSH, correct?
Correct.
You were asked about lamictal and the serious rash that could occur. You said that the serious rash is rare. How rare is it?
Approximately 1 in 1,000.
And you mentioned that millions of people take lamictal with no problem at all, correct?
That's right.
And is there anything that providers do to be aware of the potential for the rash and to explain that to patients and to try to just basically keep an eye out to see if the patient's developing that symptom?
Yes.
And what is that?
It's a medication that needs to be started at a low dose, 25 milligrams, and only gradually moving up. Finally, after a number of weeks, to a dose as much as 200 milligrams, perhaps even more. When the medication is given in a what we call titrated, slow process, the potential for this serious rash is greatly decreased. So it really is a medication that requires a slow titration. So the patient needs to be patient with that process. But it's now one of the most used mood stabilizers for bipolar disorder. That it really is a very important, valuable medicine for bipolar disorder.
And you said that it's important to start at a low dose. Did you say 25 milligrams?
Correct.
And do you recall what dose Dr. Tufts wrote the prescription for Ms. Clancy?
Yes.
And what was that?
25 milligrams.
And do you recall from the records whether the plan was, if she were to take it, to titrate in the manner you described?
Correct.
And putting aside whether or not someone chooses to take the medication because of a rash, is there any significance to the person, to a patient, being prescribed a medication and then not telling that provider that they chose not to take it?
Yes.
And what is that?
Well, it really limits the provider in making other decisions. If a decision is made that a patient is not going to take a certain category of medication, it's helpful to let that provider know and say, I've decided against it. What are some other alternatives?
Doctor, you were asked about lack of sleep potentially causing psychosis, correct?
Correct.
And sleep was definitely an issue for Ms. Clancy in the fall leading into December of 2022, correct?
Yes.
And looking back to the McLean records, would it be accurate to state that her sleep got progressively better while at McLean?
Yes.
And then directing your memory to the text messages that Ms. Clancy had with her mother from January 7th through January 22nd of 2023, would it be accurate to state that she told her mother she was sleeping better during that time?
Yes.
Defense counsel asked you if by all the evidence and witnesses that the defendant was a happy wife, mother, daughter, all of that, and you said no. What were you referring to when you said no?
Well, I was thinking about the paper that she filled out on September 12th of 2022, in which she expressed some of the concerns that she had, significant anxiety, but also, as I recall, insomnia was a concern of hers. And it was followed up with Jennifer McAllister, who worked with Dr. Tufts. And I think in Ms. McAllister's note, Ms. Clancy mentioned that she had waning confidence in being able to take care of her children as they were growing up. And that, I think in a note of Dr. Tufts noted that she said that she found that Callan needed more attention, and that as the kids were growing older, that she was finding them more challenging.
Did she give any information did Ms. Clancy give any information about why it was more challenging as the kids got older?
I'm going to object. This is pretty far afield.
Yeah, sustained. It goes beyond cross.
So, Doctor, defense counsel asked you about Dr. Tufts and her treatment of the defendant, and mentioned repeatedly how she had only been in the practice on her own for a few months. Do you remember that?
Yes.
In reviewing Dr. Tufts' treatment of the defendant and the medications she prescribed and the methods she used in prescribing those medications, did you have any issues or concerns about the approach she took or what she prescribed?
No.
And what were your thoughts about her approach to treating this defendant?
Well, possibly because Dr. Tufts was new and had just come into practice, she was more available. And so I think she was able to see Ms. Clancy over video 14 times. And for example, when Ms. Clancy was discharged from McLean, the request from McLean was that she needed immediate outpatient follow-up, and so Dr. Tufts arranged it the following day. And so there were some weeks where Dr. Tufts saw Ms. Clancy more than once a week. And I will also say that when Ms. Clancy decided to go to nurse practitioner Paul and then saw Nurse Gelada, I think early December, it might have been December 1st, she then went to Dr. Tufts, and Dr. Tufts wrote a note saying that she felt uncomfortable making prescriptions while Ms. Clancy was going to another provider. But in that note, suggested that Lamictal could be helpful. So Dr. Tufts was very responsive to concerns of Ms. Clancy in terms of seeing her. Was seeing her weekly and saw her on the 23rd of January, and then had another appointment the next week, and had talked about future treatments, possible treatments, esketamine, as well as TMS. So perhaps the fact that she had just left her residency meant that she could be more responsive to seeing patients quickly, and she did that.
And speaking specifically to the prescribing, prescribing which medications she's prescribed, which doses, what different options she tried. Did you have an opinion based on your training and experience of Dr. Tuft's method with prescriptions?
Yes.
And what was that?
I felt that the prescribing was very reasonable.
How so?
Well, back in 2013, 2014, Ms. Clancy had taken Prozac and SSRI, and it was helpful. She also took Wellbutrin and propranolol. After Dawson was born, Ms. Clancy had some significant anxiety and actually went to a doctor and was prescribed Zoloft. So this would have been in 2019. But then decided, 2019, early 2020, but then decided not to take the Zoloft. Her anxiety symptoms resolved. It was a difficult time, particularly as she got older because of COVID, but she decided that even though she had the prescription of Zoloft, she decided not to take it. The anxiety that she experienced after Callan's birth was more significant and lasted longer. And so she went to Dr. Tufts, who got a history of Ms. Clancy having taken the Prozac and done well on it, having seriously considered Zoloft to the extent that she got a prescription for it, decided not to take it, that Zoloft at 25 milligrams, which is the lowest dose, starting that, would be a reasonable choice, really perhaps the most reasonable choice of an antidepressant, given Ms. Clancy's history up to that point. I believe that there were only 7 pills taken. Ms. Clancy was directed to take 25 milligrams for a week and then increased to 50 milligrams, two tablets, but had, I think maybe after 5 days, taken that increase and increased from 25 to 50 milligrams, and then had the adverse reaction of insomnia, very significant insomnia.
And in terms of after seeing the effects from the Zoloft and stopping that prescription, the various prescriptions that Dr. Tufts tried with the defendant, did you have an opinion based on your training experience about whether that trial and error process and what she prescribed and what she tried with the defendant, whether that was reasonable?
Overruled.
Yes.
And was it reasonable?
Was it reasonable?
Yes.
Yes.
And how so?
Well, Ms. Clancy, after having the insomnia, was very upset and concerned, as anyone would be. I think that was around October 21st. And so Dr. Tufts assessed her and told her to stop the Zoloft and started her on Ativan, I understand, and Benadryl. And that medication was helpful for a while. But Ms. Clancy was concerned about Ativan, benzodiazepines being addictive, and concerned about getting hooked on these types of medications. And that is a concern over the long term. And so part of the process was to see if she could be treated effectively by decreasing the benzodiazepines or maybe giving her a longer acting benzodiazepine. The medication buspirone, was prescribed by Dr. Tufts, but Ms. Clancy, in a note.
Excuse me, Doctor, I apologize. Can I have a standing objection to the rambling answers? This is redirect. I object.
All right. We can see, counsel, I just want to put something on the record. Counsel.
And so, Doctor, if you could continue your answer.
Just for a second, I just wanted, so members of the jury, we're going to go a little past the 1 o'clock, the usual time of the break here for certain scheduling reasons, okay?
So if you could just summarize briefly what you said, that you thought that Dr. Tufts' approach was reasonable. If you could just summarize briefly why you thought her approach was reasonable.
According to the notes and also the emails, communications with between Dr. Tufts and Ms. Clancy, I found Dr. Tufts to be very responsive to Ms. Clancy's symptoms and concerns in really trying to make adjustments according to how Ms. Clancy was doing.
Thank you. And you were asked by defense counsel about her visit to Women and Infants Hospital and about the defendant. I believe what defense counsel asked you was that every time a doctor told the defendant to do something, she was on it immediately. Do you remember being asked that?
Yes.
And do you recall that in the Women and Infants records that they offered her 3 programs: an inpatient hospitalization, a partial hospitalization program, and an outpatient program, and the defendant said that she would talk to her provider for guidance about those programs?
Yes.
And do you recall reading in the notes and records of Dr. Tufts, nurse practitioner Gelada, that she never discussed those 3 programs with her doctor or her nurse practitioner, correct?
That's my recollection.
Now, in terms of the calls to Aspire, to the hotline for the suicide hotline, you were asked about where in the records you saw that, And I would just like to approach, also from Exhibit 222, the note from December 8th, 2022 of Letitia Dukes. And if you could just review this note here and then look up when you're finished. Doctor, is this the record that you were referring to that gave you the information about the defendant's call to the suicide hotline?
Yes.
And reading from this page from the exhibit, page 45, it states that patient contacted Aspire Crisis Support. She met with an Aspire clinician virtually and was told that she did not meet the criteria for inpatient treatment due to not having an SI plan, that's a suicidal ideation plan, correct?
Correct.
And then reading again, Aspire clinician recommended that the patient attend a day program. The clinician said he would be sending the patient resources. Clinician informed the patient that it would be beneficial to attend an IOP or a PHP to help the patient build coping skills and build community. What's an IOP and a PHP? Do you know?
PHP is partial hospitalization program, and IOP is, I believe, an inpatient program.
And so when the defendant called the suicide hotline, she told them she was having suicidal thoughts, correct?
Correct.
But she told them she did not have a plan, correct?
Correct.
And they didn't just hang up on her. They sent her resources and recommended a day program and a partial hospitalization program or an inpatient program, correct?
Correct.
Move to submit these two pages, 45 and 46, as the next exhibit. They're apart from Exhibit 222.
All right, subject to the same objection, I'm going to, that may be admitted.
197.
You were asked a lot of questions about hormone changes after pregnancy and if that can affect, and stopping breastfeeding, and if that could affect someone's mental health. Do you remember that?
Yes.
And you said something about the timing matters. Why does the timing matter?
Well, after lactation and a postpartum period, and it may be the decision for a woman to stop lactation can occur at various times, not just during a circumscribed 1 month period. But stopping lactation causes a decrease in prolactin levels and an increase in estrogen and progesterone. And it really depends on when someone decides to stop breastfeeding. Those significant hormonal changes that are tied to breastfeeding or lactation. And so that's why timing, and the time is important to see at what point did breastfeeding stop, and at what point are we seeing symptoms.
And doctor, with the defendant, the breastfeeding stopped sometime in October, is that correct?
Yes.
And then looking ahead to January 24th, 2023, would you still be expecting to see hormonal problems from stopping breastfeeding in October in January, that many months later?
No.
Now, you were asked about the statements Patrick made regarding his interaction with the defendant when he found her outside in the snow. And is it correct that he told you he found her and said, "What did you do?" And she said, "I tried to kill myself"?
Yes.
And did he then say, "Where are the kids?" And she said, "They are in the basement"?
Yes.
Did he then tell you that he then called 911?
I don't recall exactly when he told me that he called 911. What I recall is his statement about what she said to him.
And that was her statements to him when he immediately found her on the ground?
Correct.
Okay. And you're aware that at some point he made a 911 call, correct?
Yes.
And during that 911 call that you listened to, you didn't hear the defendant saying any words at that point, correct?
I did not.
And as a physician, are you aware that someone who's been injured can deteriorate over time?
Yes, particularly after an overdose.
And can they be speaking in one moment and then unable to speak moments later?
Yes.
Now, you were also asked about the crushed up pills and whether there was any residue on the nightstand or anywhere in the house that the police saw, correct?
Yes.
And there was no residue in the photos, correct?
Not that I saw.
But you don't know when she crushed up the pills, do you?
I don't.
If she had crushed them up earlier in the day, there wouldn't necessarily be residue, correct?
Correct.
If she had crushed them up days before and put the empty bottles in a drawer, there wouldn't necessarily be residue, correct?
It's sustained.
Yes.
There were many texts between the defendant and her mother in January, correct?
Yes.
And from January 7th until January 22nd, when Ms. Clancy's mother and father visited her at her home, the text messages clearly indicated that they were in two separate locations, correct?
Yes.
And in those text messages, the defendant repeatedly told her mother that she was doing a little bit better, sleeping's a little bit better, correct?
Yes.
You were asked about Dr. Resnick and how many articles and how many books he's written and how he's well known in this area, correct?
Yes.
And are you familiar with Dr. Resnick's teachings about malingering and about psychosis?
Yes.
And is it fair to say that Dr. Resnick teaches others that one of the red flags to look for in malingering?
You can ask him what he's read, not tell him what she wants him to say.
No, hold on. Let me hear the question first.
Are you aware that one of the red flags that Dr. Resnick teaches to look for in malingering and faking hearing voices is that someone automatically obeys a command?
Yes.
That's stricken at this time. Can I see counsel? Members of the jury, that last answer, I think, as I said, was stricken. Okay? Yeah, come on.
Thank you, Your Honor. Now, you were asked about trying to do collateral interviews with the defendant's family, correct?
Yes.
And you had requested of our office to make arrangements to interview the defendant's parents and her sister, correct?
Yes.
Were you aware that an email was sent to, were you aware that a phone message was left for Paula Musgrove asking if she and her husband would be willing to meet with you on June 11th, 2026, and that they did not return the call?
That's my understanding.
And are you aware that an email was sent to Allison Ozga, the defendant's sister, requesting that she meet with you, and her response to that email was, "I am awaiting a response from Kevin advising me on participating in Dr. Saftoff's assessment. I will respond once I speak to him." Were you aware of that?
That was my understanding.
And were you aware that she did not respond after that?
Correct.
I have nothing further. Thank you.
You weren't aware that Kevin was on a month-long federal trial during that period of time either, were you? That'd be me.
Is that a question?
Yeah.
Can you repeat it?
You could say, maybe get a little closer to the microphone. I had problems.
Aware, sir, that during the time that Ozga, her sister, said she's waiting to hear from Kevin, and I'm the Kevin, that I was on trial on a month-long federal case out of my office. You didn't know that, did you?
I did not know that.
Did you ever think to call me directly or at my secretary, my office manager, to ask about me reaching out to these people?
No.
That's all I have, Judge. Thank you.
Anything else?
No.
All right, thank you, Doctor. Let me
Thank
sit
you.
down. Thank you. All right, Attorney Sprague?
Commonwealth rests.
All right. So members of the jury, the Commonwealth has now rested their rebuttal case, so you have the evidence. All right, and so at this point, what I'm going to do is excuse you till tomorrow morning. All right, and tomorrow morning, you should be ready. We're going to have closing arguments and the legal instructions in the morning, and then the jury will begin deliberating. All right, so that's tomorrow. So I would suggest you go home, rest up, and be ready for tomorrow. And so you now have heard all the evidence. For the first time I can say that. You've heard all the evidence. But you haven't heard the arguments from the attorneys. You haven't even heard, like I said before, the law that you're to apply. So you still have to keep an open mind. All right? So those instructions that I gave you for the last 4 or 5 weeks, they're doubled down today. All right? Don't read anything. Don't talk about this. Don't watch anything. Don't discuss this with anyone. And keep an open mind. All right? Come this far with that open mind. Bring it with you tomorrow. All right? And so get a good night's sleep. I look forward to seeing you tomorrow. And we will get as soon as we can. Sometimes there's a little delay when we get to this next section. So we'll try and get you out here as soon as we can tomorrow morning. But if there's a little bit of a delay, as you probably already know, it's probably on me, right? But we'll try and get you out here as soon as we can, get you right back into this. So again, thank you so much for all your work, all your commitment, all your dedication, and I look forward to seeing you tomorrow. Okay.
Court, all rise, please. Jury, no first place on the chair.
Jurors have exited the floor of this closing session.
All right. What I thought we'd do is maybe I'll hear from the defendant in regards to any motions at this point. Then we can take a break, probably till about 2:30. Come back to the charge conference. Before you leave, I have that draft so you could impose on your lunch hour. You could be looking at my instructions. With that, Mr. Reddington.
Yes, Your Honor. I know it's not crafted by learned hand, but nevertheless, I did file a motion for required finding that I have to renew, so I'm renewing it and waive argument.
Okay.
We'd object to the motion.
All right. The motion at this point is denied. All right. And so we will be in recess till 2:30. And if counsel can just wait, and I'll get those copies. I should have brought them out with me. They're in my lobby. And then we'll be in recess. All right. All right. Thank you, everyone.
Court, all rise.
return back to the trial of Commonwealth versus Lindsay Clancy. All parties are present excluding the 18 jurors.
All right. Counsel, I thought we'd have our charge conference at this time. Everybody get a chance? I know you just got them about an hour ago. So in regards to the draft that I gave, I know I got one set of proposed instructions from the defendant. Does Commonwealth have any that you wish to offer?
We don't have the written motion, but we just do have a few comments and a.
Sure, well, that's kind of what I expected. I know everybody's been on trial, so I thought that's kind of why I thought I'd give you the draft, that we could just kind of walk through it. So my thought would be to first go through the Commonwealth's position, and then I'll hear from the defendant. Attorney Buckingham.
Thank you, Your Honor. In relation to your proposed, your draft instructions, I think that Your Honor's instruction regarding criminal responsibility is pretty much the cut and paste of the model instruction. So overall, there's no objection to it. However, the Commonwealth would just like to put on the record that we don't think that voluntary intoxication, the 3 points that were added in to Your Honor's draft are necessary, and I'll just cite to the Commonwealth versus Brown, 449 Mass 747, it's a 2007 case, where it says that an instruction on voluntary intoxication is not required absent evidence of debilitating intoxication. Such evidence must support the inference that at the time of the killing, intoxication impaired the defendant's ability to form any requisite criminal intent. And so in this case, I understand counsel is going to argue, medications, and he's free to argue that to the jury. But as far as instruction goes, we're talking about criminal responsibility. We're talking about mental status at the time of the event, on the day in question of January 24th, 2023. There is no evidence to support that there was intoxication to a debilitating effect, as the Brown case indicates. I think what the best evidence the court has is that the defendant, in her journals and in some statements that she made to the experts, indicated that at the time of the offense she was taking amitriptyline and one other medication that she had been on for quite some time. And Your Honor now has evidence that it was a very low dose of amitriptyline, and there is nothing about the observed behavior of her on that day suggesting that there was any debilitating effects of the consumption of the prescription medications on that day. So we would ask that those sections not be included in the instruction. If Your Honor is inclined to include them in the instruction, we are asking that you add a qualifier into it's what's listed as paragraph 3, where it starts to talk about.
Is that on page 3, kind of Roman numeral 3?
Yes.
Okay. All right. Yeah.
It says the defendant who lost a substantial capacity I have just described involuntarily intoxicated by prescription drugs. We would just ask that you add on the day of the offense to, again, just be clear to the jury that we're talking about her consumption or the consumption of the medication on that day. I did notice a quick typo on page 4 under Roman numeral 4 in that first full paragraph where it's the consequences of a finding. It says in the maybe 5th line, it starts, if the court concludes the defendant is mentally ill and that her discharge would create a substantial likelihood of serious harm to himself.
Okay.
It's just a pronoun.
Right. Okay. No, I appreciate that.
As far as the remaining charges, instructions on the charges of first degree with deliberate premeditation and extreme atrocity or cruelty, the Commonwealth has no objection to that. I would just note another typo on page 7. Where Your Honor lists out the Castillo factors. On the third factor, C and D appear to be on the same line, and there are just some numbers in there that I don't think make sense. This is the manner and degree and severity of the force used.
Oh, I got you. Yep.
And as far as the instruction on involuntary manslaughter, the Commonwealth would object to the involuntary manslaughter, and I would cite to the case of Commonwealth versus Garabedian, which is an older case, 399 Mass 304. It's from 1987, and it says that the defendant, in that case, the defendant argued that involuntary manslaughter was required because of evidence of involuntary chemical intoxication. That was a case where the guy was he sprayed chemicals on lawns, and he had an interaction with a homeowner and ended up getting into a physical altercation with her, strangling her, falling off a ledge, hitting her with a rock, and then strangling her with a shoelace. So in that particular case, the court held that an unlawful battery was quite likely to endanger life and hence could not be classified as involuntary manslaughter. So where it's a wanton and reckless conduct theory, I think that Garabedian is right on point to say that in situations like this, where we have the strangling of the individuals, of the babies, of the kids, unlawful battery is quite likely to endanger life, that it shouldn't be an instruction for involuntary manslaughter. So I'd rely on that case to argue that that is should not be included in the instructions. And there's one more point. Your Honor, at one point when we were arguing about particular pieces of evidence and duplicative evidence, Your Honor did indicate giving some sort of instruction about the jury didn't consider the fact that there might be duplicative evidence as giving any more weight or importance. And I know you do have a small line in that where it says in the what is evidence section about the strength or proof is not determined by the volume. But I do think, again, based on the particular way in which the evidence came in and how the parties chose to display the evidence, and the fact that we have text messages in several different forms that are presented, some of them the full record, some of them condensed records, that some instruction to them that indicates that they're to give no more weight to any one than the other, even if it does appear duplicative in the record. I'd ask that something to that effect be added.
I think it says that on page 11, because I do remember that request. If you look at under what is evidence, in this case there may be certain documents or photographs that are entered multiple times. This does not mean that that evidence is any more or less important than any other evidence. So, so I put that in there, and I understand the request to maybe put that in a separate paragraph, but I have addressed it that way. I'll consider not whether I give it a separate paragraph. I do understand the request, but at least that's why I put that in there. All right. Anything else? Okay. All right. Mr. Reddington.
Thank you. Thank you for the time to review this stuff, Judge. If I may, just going through your proposed instructions, Roman numeral 1, introduction is fine. Criminal responsibility, paragraph 1 is fine. Going down in page 2, criminal responsibility, you indicate is a legal term. Not criminally responsible with a mental disease or defect, and then you make reference to lacking substantial capacity either to appreciate criminality or wrongfulness of the conduct or conform the conduct. That's fine. And then you define you don't define it, but you talk about mental disease and defect. I understand that the law is pretty clear that the court does not have to define mental disease or defect, but you've given them a framework within which to make that decision, which is acceptable to the defendant. There is one reference in there where, if I may, does not include abnormality, only by computer crew. So you say in that sentence, the phrase mental disease or defect is a legal...
Let me find that.
I'm sorry, it's page 2, second paragraph down after that first sentence.
I got the phrase, go ahead.
Yep, mental disease or defect, in quotes, is a legal term, not a medical term, that's fine. It need not fit into a formal medical diagnosis, fine. The phrase, quote, mental disease or defect does not include abnormality. This is what I'm just looking at. Characterized only by repeated criminal conduct So number one, I just would suggest, I don't think we have repeated criminal conduct here. I'm just wondering if that might just be a little confusing. It is for you to determine, in light of all the evidence, whether the defendant has a mental disease or defect. If the Commonwealth has proved to you beyond a reasonable doubt that the defendant was not suffering from a mental disease or defect, Commonwealth has satisfied its burden of proving that defendant was criminally responsible. So I understand and have no problem with, I would think, all the way from it is for you to determine. My only question is in reference to where you put in the phrase about mental disease or defect does not include an abnormality characterized only by repeated criminal conduct. I don't think that that's based on the evidence, so it might be hypothetical, but I just assume not have that in. Next paragraph, if the Commonwealth has not proved to you beyond a reasonable doubt the defendant was not suffering from a mental disease or defect, then you must consider whether, as a result of mental disease or defect, the defendant lacked substantial capacity either to appreciate or the wrongfulness of conduct or conform. That's a fair statement of the law. To establish that the defendant had substantial capacity to conform her conduct, the Commonwealth must prove beyond a reasonable doubt that any disease or defect that may have existed did not deprive defendant of her ability to behave as the law requires, that is, to obey the law. And then you do indicate that that would relate to the word appreciate, understand, more than merely to know. And then criminality, and then you do get into means the legal significance of conduct, and wrongfulness means the moral significance, which is fine. I would ask that on the next paragraph you add in before wrong in the second sentence, Commonwealth must prove that the defendant knew and understood that her conduct was illegal or it was, and I would ask that you put in there morally wrong in front of wrong. And then the rest of that paragraph is fine from my point of view. Last sentence, the court notes, defendant must have been able to realize in some meaningful way that her conduct was illegal or wrong. And again, I would just ask that you would insert the word morally wrong. That paragraph is fine. Roman numeral 2. A defendant's lack of criminal responsibility must be because of a mental disease or defect. That's fine, but then the court says all that you need to determine, and I just would ask respectfully that you delete the all that you need to determine. It seems to kind of, and I know that's in some of the instructions, but I think it kind of dilutes the gravity of the issue for the jury. It's almost minimizing the burden for the government, and it's unnecessary, so I would ask that that go out. And then you could say the jury has to determine the issue and then go into the rest of the instruction as you put it, rather than saying all you need to determine. Further in that paragraph, where defendant lacks substantial capacity to appreciate, again, that's appreciate the criminality or wrongfulness of her conduct or to conform her conduct to the law solely as, okay, voluntary intoxication. Believe it or not, after 5 weeks, I think we agree. I would ask that the court not instruct on voluntary intoxication. I appreciate the fact that looking at the model charge, and I know when Your Honor is using that as a guide, they do make reference to voluntary intoxication. I just don't see that there's any evidence here of voluntary intoxication that would trigger a pre-existing mental disease or defect. I don't see that there's any issue such as a lot of the cases, as you well know, when you're dealing with a defendant who's snorting cocaine or shooting fentanyl or smoking weed. I know the case, the recent case of Commonwealth versus Aldo Dunphy, D-U-N-P-H-E, is a guy that had a marijuana psychosis, dependency, and we don't have any of that here. We just have prescription medications that were provided to the defendant. So I would ask that the court not reference voluntary intoxication. I would ask, going down to Roman numeral.
So would you ask, so Roman numeral 2 on page 2, not give?
Yes.
And Commonwealth, that you would be in agreement with that?
Yes, but I think like 2 also follows with Roman numeral 3.
We haven't got to 3, so I want to make sure that, but I just kind of want to make sure as I'm going through this, it's kind of dense. you know, as am I sometimes.
Yeah, it is.
So I just wanted to make sure. So Roman numeral 2, both parties are of the position not to give based on the evidence as it's developed.
Correct.
Okay.
Yep,
All right.
thank you.
I'll consider that. I'll strongly consider that.
All right.
And then, so that takes us to paragraph 3.
In paragraph 3, if I'm not mistaken, I did skim it pretty quickly. I think it does also reference voluntary intoxication. Yeah. And here you're specifying prescription drugs, and if the defendant knew or had reason to know that her intoxication would trigger or intensify a mental disease or defect. I don't think that the evidence supports that. I agree with the Commonwealth. I would ask that Roman numeral 3.
All right, so by agreement, nobody's requesting paragraph 3, correct. And I'm highly likely not to give that.
All right. 4 is fine, Judge. Roman numeral 5.
4 goes to the same thing. It's just a reiteration of the final. So if
yeah,
we're
so that would go out. Yep.
4 is kind of a trailer to 3. Okay.
Roman numeral 5 is okay. Paragraph 3, 4. Okay, so again, if I may just say, without skimming them now, anytime it's referencing voluntary intoxication, maybe that could be deleted. Because I see in paragraph 4 on Roman numeral 5 on page 3, it does reference again for voluntary intoxication from prescription drugs and that type of thing. So that would go out. Paragraph 6, talking about in the event that the defendant is indeed acquitted by reason of lack of criminal responsibility. I know the court has the obligation to instruct the jury as to what potential ramifications would flow from that. I believe that's a fair statement of the law. Instructions on murder in the first degree, deliberate premeditation, cruelty and atrocity, those are all fine. Second degree, that's fine. Involuntary manslaughter, I do think certainly the facts as presented and the evidence does justify the instruction as the court.
Let me hear you. What's the argument in regards to the involuntary manslaughter?
Well, the argument regarding the involuntary manslaughter is clearly that the defendant intended the conduct that resulted in the death of the deceased, and the conduct in the event that it was not such that her conduct was as a result of her suffering from a disease or defect, intentional, premeditated, and intended to be cruel and atrocious, that would reduce it down to manslaughter, and it would most certainly be wanton or reckless. I will be addressing voluntary as well, but I think it's clear that on the evidence that if the jury determines that defendant committed an act, defendant, as a result of the act, the victims were indeed died, that there's a high degree of likelihood that substantial harm would result to the individuals as a result of the defendant's conduct, but yet we're not talking about a disease, a defect that rises to the level of not guilty by reason of lack of criminal responsibility. You would then revert to, or default, if you will, to the standard of wanton and reckless conduct. And we know that wanton and reckless conduct under the Lansky case, basically if a defendant does an intentional act that is not just negligent, it would have to rise to the criminal standard or the criminal level of being wanton or reckless. So I think that that would, in fact, justify an instruction on involuntary manslaughter. If you want, I can continue with the voluntary manslaughter that I would ask the court to instruct. And that would relate to the issue of diminished capacity. I know the court is very familiar with Commonwealth versus Gould. I believe it's 300 Mass 672. Supreme Court decision, Patterson versus New York, that talks about evidence of a defendant's emotional or intellectual or mental state of mind that does not rise to the level of lack of criminal responsibility, but it could certainly rise to the level of extreme emotional disturbance, that would be manslaughter, not murder, and that would be under and consistent with the United States Constitution as well as the Massachusetts Constitution, because in addition to Commonwealth versus Gould, we have case law, as I'm sure I know Your Honor is aware, that talks about diminished capacity. It talks about mental disease or defect. If in fact there's evidence of a mental disease or defect, mental impairment, but it does not rise to the level of lack of criminal responsibility, then under all of those cases I just cited, plus Garabedian at 399 Mass 34, as well as my old case of Thomas Toolin, 490 Mass 698, you can have evidence of mental disease or defect that does not rise to the level of lack of criminal responsibility, but it would mitigate or reduce from the ability of the person to know that what they're doing is in fact cruel and atrocious, to know what they're doing does constitute premeditated malice, a forethought. We all know what the concept of malice is. You get the 3 prongs of malice. There's no doubt that mens rea is important on the concept of malice. And if a jury says, well, look, the evidence is that she was going to these doctors, that she was getting prescribed medication, she was taking the medication, she was in a postpartum depression stage. I don't buy the postpartum psychosis, but I think that clearly she was over-medicated or had medications that she was involved with, plus her postpartum depression. That would then justify them to say it reduces her ability to think, to react, to know as it relates to malice, which under those cases I cited would reduce to voluntary manslaughter. So that would be voluntary manslaughter. The willful wanton conduct would be involuntary manslaughter. Reasonable doubt obviously is fine. All the rest of the instructions that you gave or that you would give are fine. I would ask that the court consider the prospect, and by way of considering involuntary intoxication, and I did cite a couple of cases, Commonwealth versus Wallace and Darsh, Piantadozzi, as it relates to evidence of involuntary intoxication. And that would apply if, in fact, there's no intentional ingestion of cocaine or some type of illicit drug, but in fact it's a prescription drug that she was ingesting consistent with the drug instructions, if you will. You know, the drug laboratories and the pharmaceutical companies, they market these products. They have, some of them have black box warnings on them. We've talked about that a little bit in this trial, talked about the age cutoff, but nevertheless, it's scary stuff. You're talking the selective serotonin uptake inhibitors, you're talking about tricyclics, you're talking about antipsychotics. So if, in fact, this young lady did not have a disease or a defect that rose to the level of lack of criminal responsibility, but as a result of the drugs that she was prescribed, not abusing, not mixing with illegal or illicit drugs, that would allow a jury to determine that it would be manslaughter based upon the involuntary intoxication. And finally, I would ask that the court entertain giving a Bowden charge in this case. We know that the case law under Commonwealth versus Bowden allows the court, upon evidence presented to a jury, of inadequate police investigation. Because if you recall, way back in the day on this case, I did move for a bifurcation, and my argument to the court was that defendants in lack of criminal responsibility cases are really hogtied, if you will, because to have the lack of criminal responsibility, you have to admit involvement in the crime, but yet when you're trying the case with lack of criminal responsibility, the government still has the burden to prove to a jury beyond a reasonable doubt that the defendant is guilty of, based on the evidence, that particular crime. And if there's evidence of a police investigation that is deficient, a jury does have a right to consider that as a basis of an acquittal. They can consider that for purposes of finding reasonable doubt based upon the lousy investigation. In this case, it wasn't just a lousy investigation. It wasn't even an atrocious investigation. It was no investigation. In this case, Judge, the police, I think we all would agree, even the government, they basically accepted the fact that she strangled the kids are in the basement, she's guilty, and we move on. They didn't investigate anything. They didn't test the screen. They didn't even take a picture of the screen. They didn't see if there's any blood on the screen. There's no crushers for the alleged crushing of the medications. There's no indication that there's powder that she was crushing the medication to ingest the medication. There's all sorts of questions regarding the blood spatter, the blood. The police never investigated. They come into the court, they talk about their investigation through the crime scene laboratory and state police, and every question that I would ask about the door, about the blood drop on the door, about the siding, they come 6 months later or whatever, they take the siding, it's degraded, they can't even test it. I could go on and on and on with the horrific investigation in this case. So I think it would be fair for the court to instruct them on Bowden. That's it.
All right. Commonwealth, I know there was one, well, there were two requests I think that were, you may not have been aware of, but I wanted to give you an opportunity to be heard. One is the Bowden instruction. Also, one is the voluntary manslaughter. Before I let you do that, if I'm looking at the instruction that I have as a possible instruction regarding involuntary manslaughter, Mr. Rankin, doesn't, if we took the word involuntary out of there, doesn't that instruction there apply to the argument that you're making, considering the last paragraph?
I'm sorry, which paragraph?
Yeah, up on page 8.
Okay.
We're talking about the manslaughter instruction.
Yes, I do.
It's in the last paragraph, it talks about the ability to consider evidence from either a mental impairment or consumption of the prescription drugs.
No, I agree with that, Your Honor. If we were to fashion that, I think that instruction would
So just one instruction.
Voluntary, involuntary, it doesn't really matter.
That's what I wanted. That's kind of what I was thinking, just to go.
I agree with
if
that.
I give it, it would just be one instruction, and I wouldn't name it either involuntary or voluntary. It would just be if I give that. Okay. All right. And I think Attorney Buckingham, I don't know. I know the Commonwealth objects to that anyway, so I'm not asking for the assent on that. But what about the Bowden instruction?
So, Your Honor, we would object to the Bowden instruction. Again, counsel is free to argue whatever he wants about the police investigation in this case, but as far as failures of the investigation that have been identified in the course of the trial, I don't see that there is any. And everything that Attorney Reddington just said about what they didn't test, they didn't test the screen. Well, there's clear photographs of the screen and the condition of the screen, and that was very apparent. That was done on the day of the incident. It was documented. Witnesses testified about that. Witnesses gave statements about the window in and of itself. The blood on the outside of the house was observed. There's been adequate testimony about why it wasn't swabbed on that particular day, and there also has been adequate testimony about subsequent decisions to go back and get information or get the swabs from that area and what testing was done, and that there was testing done to identify that it was the defendant's blood that was on the outside. So I think that the evidence, the claims have been made, but the evidence shows that there has been an adequate police investigation. The only point of contention appears to be the drawer and the pill bottles, and there's been some claims made about things that were not done about those things. But again, I think there's been adequate testimony about why those things weren't flagged on that day of the incident. Police weren't aware of the fact that there was actually an ingestion of medications on that particular day. And when they did notify, or when they were aware, we had prescription bottles that were provided by Patrick Clancy, but those bottles in that drawer conveniently never got produced for testing or further analysis. So I think, again, he's free to argue it. I don't think it rises to the level of an instruction. And just to kind of as a side note on a comment about involuntary instruction, I don't think there is one. So I would ask that the court not consider that, because I don't think there is an actual instruction about it. Again, counsel is free to argue that in the form of intent, in the form of whether the Commonwealth has met its burden regarding criminal responsibility. But as far as I can find, there's no particular instruction on that. And if Your Honor were to provide an instruction, then according to the case law, if it's raised to that level, then we would have the burden of proving voluntary consumption, which would put all of that back into play that we've now disagreed with.
All right. Well, I am going to give a manslaughter instruction in line with basically what's on page 8. I am not going to give a Bowden instruction. The defendant is free to argue that any deficiencies that he feels that are in the investigation, certainly free to argue. I will not give the voluntary intoxication instructions in regards to the criminal responsibilities. So I'll have a better draft in the morning, but I just kind of wanted to let you know what the instructions are so that you can prepare your closing arguments. In speaking of those closings, how much time do you think you may need on that?
I'm usually pretty quick. I would say half hour.
I was thinking more of an hour.
All right, I was thinking of all the testimony, all the exhibits. If the parties want an hour, you don't have to use it all. And like I said, I've seen all three of you try cases, so I know you'll be making progress. So if it gets to 1 hour and 1 minute, I'm not going to push the button. So just so we can kind of have some estimate. All right. Anything else we need to address, you think, before tomorrow?
No, thank you.
No.
All right. Well, Counsel, again, thanks for all your efforts in regards to this. So I'll have a full copy of this first thing in the morning, and we'll do arguments of charge, hopefully as soon as we are ready tomorrow morning.
There is one other minor matter that we've talked about. There is that police report, the security sergeant from the hospital, Brigham and Women's, that we're going to redact and just reduce to like a paragraph. She's the one that I summons, but she's on maternity leave. And we could introduce that, just that one paragraph. And we're missing one exhibit, which is the Infants Hospital in Rhode Island, but we're going to look and see if the government has it.
We don't have it. I thought that, but we'll double check. I thought that defense had decided not to put in anything from that report because he was going to provide a proposed stipulation for that portions of that report, and then he didn't. So I didn't think that, and then we both rested, and then I rested again. So I didn't think that was coming in, but I'm happy to look over what defense is wants to stipulate to.
All right. So why don't we do that? If there's a need to technically reopen the case so that the parties could put in what they thought they put in, if it's by agreement, if it's just in regards to some of those records, I think we could do that. So anything else?
No.
Oh, how about redactions? That was the other thing. Was it just that one report, a couple reports we're going to have to deal with?
I believe that everything that required redaction has been redacted.
All right.
I think so. Yeah, I'm not aware of anything we have to.
All right. I'm just asking. All right. All right. So thank you very much. We'll see everybody tomorrow morning. All right. Thank you.
Court, all rise.